Good morning and welcome to Bradford Health Services' first education event for 2023. My name is Kendra Helmsley and I'm a territory manager at Bradford Health Services. I'm the territory manager for the Birmingham-Tuscaloosa area. And so that means I work as a point of contact should you need to make a referral to Bradford. I'll post my cell phone number in the chat should anyone need a point of contact for making a referral. I want to thank everyone who is joining us today. Bradford hosts webinars on a quarterly schedule. We offer 3 additional webinars in 2023, so make sure you check our website for any upcoming events. I will also include a direct link to our events page in the chat box for you to check out our other scheduled events. Before I introduce today's session, I want to share some important information with you. You are viewing this in a webinar format, which means that you can see the presenters, but your video and audio are off. Please either use the chat or the Q&A functions located at the bottom of your screen to ask questions regarding anything discussed or to communicate with our presenter. At the end of the presentation, we will have a discussion where questions received will be answered at that time if the presenter does not answer them previously. Please note that you will receive a post-session email that will include a link to materials presented today and referenced today, as well as a link to a video recording of today's presentation. Today's session is eligible for 3 continuing education contact hours. Bradford Health Services is providing continuing education contact hours at no charge to you. Your attendance and participation today are being recorded through your login, so there is no need to put any additional information in the chat box. After the conclusion of today's presentation, you will also receive an email with a link to an evaluation. The survey link will be open for 30 days post-webinar. You must complete the evaluation in order to receive credit for your participation. After completing the survey, you will receive your certificate within 2 weeks via email. Late submissions 30 days after today will not be accepted. Therefore, continuing education credit will not be awarded in that event. So make sure you complete the survey as soon as possible. If you would like to complete the survey immediately after today's event, we will include the CE evaluation link in the chat box near the end of the presentation. We are expecting a large attendance for today's session, so your patience is appreciated regarding the education components, as we have 1 staff member that processes all of the evaluations and certificates. Finally, if we experience any technical difficulties today, please stand by while we do our best to resolve them. If the webinar gets interrupted in any way, we will get logged back in as quickly as possible. Now that we've got the housekeeping issues out of the way, I would like to introduce our session. We're excited for today's session titled Navigating Addiction Treatment, an overview for providers. Our presenter today is Zach Ludwig. Zach is a licensed professional counselor and serves as the Vice President of Clinical Services and Accreditation for Bradford. He has had multiple roles within the company over his 12-year tenure and will tell you more about himself during the presentation. I hope you enjoy the presentation. I will now turn it over to Zach Ludwig.
Thank you very much. Good morning, everyone. Welcome to, as Kendra was talking about, our first presentation of the year. For those of you who have played along at home in the last couple of years, we do these fairly routinely. Lots of exciting things coming up this year. She did a great job doing an introduction as briefly as possible, which is exactly what I expect. I really don't want to spend a lot of time on me. Here's who I am, though. Picture me on the screen. Good thing I'm not wearing the same outfit today. I am a licensed counselor in Alabama, Tennessee, and Florida. Been with Bradford in total since 2011. Been at corporate here in Birmingham, Alabama since 2016. A few different roles, all in the scope of clinical operations, clinical programming. Very happy to be talking to you today about this interesting topic. It's titled Navigating Addiction Treatment, an Overview for Providers. When I was putting this together, I was trying to picture the person that maybe doesn't work in this field routinely every day. Bradford is a substance use treatment provider in the Southeast, operating in multiple states with different levels of care. I know that that's not the setting that most people work in. A lot of folks who join our webinars are in private practice. They work for agencies that specialize in mental health. And while all of you certainly see substance use disorder or those who are struggling with emerging addiction, it may not be your expertise. So what I wanted to do in a brief amount of time is give you some overview of how treatment works, things that a patient or family member might expect if they were entering into treatment, what makes treatment effective, what can make it ineffective. We're going to talk about some barriers to getting people into treatment. We're going to talk about some neurobiology, about how drugs and alcohol affect the brain. We're going to talk about some trends with drug use and alcohol use that I'm bringing you some of the latest information, some of the latest trends, maybe things you're unaware of. And I think it's good for us as providers, but also just citizens of the world to be aware of. Then we're going to circle back. We're going to talk about qualities of a provider that I think are important. And then I might give you some focus areas for the future. Again, maybe some things that you're not as plugged in about, but some things in literature that I think are going to be focus areas moving forward. I do want to circle back on a couple of very important issues. One is the technical issues. If we do have technical issues, we're going to try to get back on as quickly as possible. Watch your emails for any major issues. I'm looking out the window here where I am. It's rainy, but not thunderstorms, so we should be okay. Somebody knock on some wood. We got lots of chat going on. I appreciate the chat. I am pretty good about watching the chat. I see people are asking about attendance. If you're logged in here, we are registered, we see you, you are going to get an email with all the info on CEs. But if you want to interact with me during the presentation, because I can't see you, I can't hear you, chat is the best way to get my attention. If you want to ask a question, I'm going to do my best to answer it. If by any chance I do not answer your question live in the moment, don't take it personal. I might circle back to it. I might already have that plan to talk about in just a moment. So I might not give immediate attention to it, but I am watching and I do want to interact with you because I think that's what makes these fun for me. I don't like just talking for 3 straight hours. I like to have a little back and forth and hear from you. So without further ado, let's dive in to our first section of the presentation, which we're going to talk about some trends in substance use in general. So latest data that anybody can get is from 2021. There's always lags on data. A lot of this early data I'm going to show you comes from SAMHSA. There are links available in the resources you are going to be provided for these references. In 2021, about 61 million people, which was up by a couple million from the previous year, used illicit drugs in the past year. So very important terms here. We're not talking about substance use disorder. We're talking about they just used, and it's an illicit drug, and this is in the past year. Okay. A lot of those are marijuana use. That's about 52 million people using marijuana in the last year, and about 9 million people who are misusing opioids. Misusing opioids means they are getting a prescription painkiller that is not prescribed to them, most commonly through family members, stockpiles and medicine cabinets that family tend to have, or it is overusing one's prescription by overtaking it in quantity or in greater frequency than is indicated by your prescription. When we move that into just the past month substance use, and we look at age 12 and older for the year 2021, 57.8%, that's about 160 million Americans, used tobacco, alcohol, or an illicit drug in the past month. So that's why that data looks a little bit different. If you're looking at those numbers and you're like, that doesn't jive with the previous slide, trust me, it does. I've looked at them a lot. You got to look at this in the scope of the past month. About 133 million people are drinking alcohol in the past month. About 54 million people are using a tobacco product. And about 40 million people are using an illicit drug, again, with the primary one of those being marijuana. 60 million people were in the past month considered binge drinkers. And we're going to talk a little bit more about what that definition means later on. But this is high, that you see this highest amongst the emerging adult age group, that 18 to 25, that college or college interrupted age group. Then you see it among those who are older than that, age 26 plus. That's a pretty big amount of people. That's a large demographic, followed by adolescents. Yes, Crystal's asking if the slides are going to be available. Absolutely. We're going to send you a copy of all these slides whenever we send you the eval link, because I'm going to move through some of these quick and I want to make sure you get the information. Yeah, somebody's asking about COVID. Oh, I'm going to tell you all about what COVID did to these numbers. It is significant. Adolescents are drinking less. They are turning more towards marijuana, and they are using cigarettes in the way that many of us experienced nicotine in the past. They're moving away from cigarettes. That's kind of not that's not as cool anymore. Now they have the vapes. So there is a lot more movement towards that, and we're going to talk a little bit about that later on. But this is not an adolescent specific training. So we have a lot of people who are using drugs or alcohol. Using is differentiated from substance use disorder in a number of ways. We move from a point of non-use, an abstinence, to a point of use, and for a lot of people, nothing bad happens. They drink their glass of wine with dinner on a date night, and no problems. They go about their lives and they do not face consequences. It is the compounding of the negative effects, coupled with the continued use of the substance, that propels that use into a point of problem. And there's lots of terms we've used historically, misuse, abuse, dependence. Abuse and dependence used to be the way diagnostic worked for this. Now we put it into substance use disorder as the category, and depending on the severity of that, we have mild, moderate, or severe diagnoses. I'm going to show you a little bit more about diagnoses as we go. But this can happen where people can move into this problematic place and can pull back from it without significant intervention, without seeking treatment. That certainly can happen. People can qualify for a mild, moderate, severe, or possibly even severe use disorder, and through time, through the remaining abstinent, no longer qualify for that diagnosis. However, because of the nature of substance use disorder, which is a chronic condition, it is likely that it will resurface again and will require additional intervention as time goes on. That prevalence of the use disorder, which is going to be the main focus for what we talk about, is fairly wide in scope. About 16% of the American population, that's about 46 million people age 12 or older, based on data out of 2021. And the most common use disorder is alcohol. Sometimes that surprises people because, of course, we hear so much about opioid use disorder, and definitely is a problem. We're going to talk about that. But the number one drug for which people seek treatment is still alcohol. And if you think about it, there's a number of reasons for that. It is accessible, very much so. It is socially acceptable. So people can have that initiation of use. They have a reaction to it. Their brain likes it. It creates this reinforcement. Pattern of use continues. It starts to become problematic. That develops into that dependence. The other reason why people need to often seek intervention for this from a treatment facility is once it gets to a point where someone has been drinking a significant amount over a period of time and they choose to stop, it might not be all that easy. Alcohol is one of the just few substances that, if not handled medically, could result in death. The withdrawals from alcohol can be severe, resulting in things like delirium tremens, seizures, cardiac issues, and possibly even death. So it, along with benzodiazepines, must be treated with great respect in the detox process. Now, all substances have a withdrawal experience of varying degrees. Even marijuana, if someone is a chronic user of marijuana, no pun intended, once they stop smoking marijuana or ingesting it, however they are, they will have a bounce back effect. Those neurotransmitters are going to they're going to react to it in some way, and we're going to talk a little bit about how that process works. But they might have increasing anxiety, sleep disturbances, appetite disruption, things like that. So getting back to this slide, about 24 million people had an illicit drug use disorder. Again, when you break down those, we see a lot of marijuana, you see pain relief, prescription pain pills, methamphetamine, other stimulants that could be like prescription stimulants, cocaine and heroin, which, as I think I saw somebody say in the slide, like surprise is kind of low. It's low because heroin it's stalled out a little bit as people are moving more towards the synthetic opioids, fentanyl, and adulterated counterfeit prescription pills, which I'm going to talk about as well. Heroin is still out there, of course, and it is still being used, but it's often secondary to some of the other opioids we see primarily. So let's talk about how one lands on a diagnosis. I know not everyone on this call does diagnosis and things like that, but I think it's important to have an understanding of how one lands on this criteria. There are 11 criteria for substance use disorder. I'm going to read through them pretty quick. If you take it in larger amounts over a longer period of time than was intended, persistent desire or unsuccessful efforts to cut down or control that use, a lot of time spent to secure the substance, use the substance, recover from it. Cravings or strong desire to use the substance, recurrent use that results in failure to fulfill major role obligations such as school, work, home obligations, continued use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of the substance. They never intended for this to be read that fast. Important social, occupational, or recreational activities are given up or reduced because of the use, recurrent use in situations that could be physically hazardous, and use despite the knowledge that it might have a persistent or recurring physical or physiological problem that is likely caused or exacerbated by the substance. Those mean all kinds of different things. There are 9 of them there. Those are all very important. They help in determining the level of severity. That coupled with the 2 on this screen, which have more nuance, tolerance and withdrawal. Tolerance is as you take a substance, it stops having the same effect as it did that very first time. It works that way for pretty much every substance that is ingested. And because of that, people tend to need to ratchet up how much they are ingesting to get those same desired effects. Also withdrawals, which could be manifested by either the following. It's again not present with every substance, mainly hallucinogens, things like that. Characteristic withdrawal syndrome for the substance, those vary, and the use of the substance is taken to relieve or avoid the withdrawal symptoms. You see a lot with that with opioids and alcohol, benzos to a degree, but people, at some point it's like not getting high, just trying not to be sick and ill, and that is the goal. And I think that gets distorted a lot when we think about people who are using substances. To a degree it's chasing a high, but for many of the folks who get to the point where they're needing treatment intervention, it's just so that they don't feel awful. So there's 11 of these. If someone has 2 to 3 of them, we would say they have a mild use disorder. If they have 4 to 5, we would say they have a moderate use disorder. And for those with 6 or greater, we would say they have a severe use disorder. There are specifiers such as remission time. That's based on abstinence, and it's based on a amount of time. You have in a controlled environment, such as if they are in a place where they cannot use. I want to say jail, but I know that there's a whole lot of use that happens in jail, so let's not throw that one in there. But it could be in a treatment facility or in some other secured place where just they're not able to use even if they wanted to. And then on maintenance therapy, which is mainly for talking about opioids, that would be MOUD or MAT, which we are going to talk about today as well. So we have diagnostic criteria. It's important that as we are interacting and diagnosing and trying to work on preliminary treatment course of action, that we're using proper terminology. There's a lot of stigmatization with substance use disorder in a way that I don't really see with other mental health conditions. It's important that we are demonstrating non-judgmental language. We're not being biased in our language. So always using the person first language. It is a person with a substance use disorder. Same way we would say it is a person who's diagnosed with schizophrenia versus just saying the schizophrenic. There's lots of ugly language that can exist in this space. This graph here, it's sorry, it's a little blurry, but it shows some of the things that are either just inappropriate or outdated. As I said, we don't really say abuse anymore. Abuse disorder, something like that. We say disorder. They're not abusing their drug; they are using it, and it's causing a negative effect for them, and that's something that they'd like to work on. And we don't say things are habits. We don't say things are problems. This is a disorder. It is a condition. It's medical. We have to follow a medical model to avoid this bias that exists. You see this with drug screens. We talk about if somebody takes a drug screen and they have a positive drug screen, what does that mean? It means that there was a detectable presence of the substance in the sample. It doesn't mean that they were dirty. That puts a lot of negativity on the screen itself, but on the person. We don't call them clean, we don't call them dirty. They are positive or negative. Even MAT, which I mentioned, medication-assisted treatment has become less in use of the last couple of years. Now we say things like MOUD, medication for the treatment of opioid use disorder. Why do we do that? Because when we talk about it as medication-assisted treatment, it talks about it as an adjunct. It's only a part of. It's less important. Whereas when we talk about MOUD, the medication is in itself the treatment, a treatment, and it is a evidence-based standard of care, and it needs to be recognized as individually significant. So that's what that bottom part is, a lot of differences there. People struggle to access treatment, period, just in the world. And among those who are 12 and older in 2021, according to this survey, about 15% people needed substance use disorder treatment in the past year. That's about 43 million people. So if you do that difference math, that means about 3 million people, based on this study, got treatment, and a lot of them, majority, did not. 40.7 million people with an illicit drug or alcohol use disorder did not receive treatment at a specialty facility. I think that's an important descriptor in that sentence. What were the reasons? According to this study, about 97% of the folks said that they did not feel that they need treatment. I'm going to talk about that in some detail today. That's the vast majority of that sample. 2% said that they thought they needed treatment, but they did not actually make efforts to get the treatment. And about 1% said that they felt that they needed treatment and they made an effort to get it, but they could not access it. This is a problem in healthcare in general. This is a problem in mental health care, but it has varying degrees of problem. People who need medical care, plenty of people will push that off. They will choose not to seek medical care for whatever reason, fear, costs, etc. You see people who are not accessing mental health care for those same reasons, and then adding in stigmatization. Drug use treatment, has probably the greatest degree of stigmatization of any mental health disorder. I would argue, because so many people think that this is something that is within someone's control to just stop, and there's this belief that exists largely outside of, hopefully, this community that I'm talking to right now. But that puts a lot of barriers up, and it creates this problem with having access to providers as well, because treatment centers can struggle to even operate in certain communities because there is a not in my backyard kind of mentality against, quote unquote, those people who are using drugs. And this exists, even with residential centers that we're trying to open up. It especially exists among medication providers like methadone clinics. There is a great deal of barrier that exists in the world for people getting treatment. I like this particular study, and you can always look these up on your own. I give you all my resources. This gave a little bit more detailed breakdown about why are people not getting treatment? What is going on with this treatment gap? And this gives us some slightly different numbers from the previous slide. It says about 40% of people were not ready to stop using. I've heard that. That is not an uncommon thing for people to say. And to me, I appreciate people that have that level of honesty and self-understanding. Now, there are things we can do to address that. Some of this comes from people who are underestimating their problem, the severity of their problem, or they overestimate their ability to control it. That is likely coming from denial, and denial is going to come up a number of times in the preceding slides. About 30% of people do not have healthcare coverage; they cannot afford it. About 16% might have a negative effect on their job. 8% think that it's going to cause neighbor or community to have a negative opinion of them. 12% do not know where to go to treatment. Another 12% do not have transportation, or programs are too far away, or do not offer convenient programming. And about 11% do not offer the type of treatment desired by that person. And again, some of that goes into the over or underestimating of what they think they need. Some people want to think that they could do with the very, very least, when really they probably need medical stabilization because of what they've been using and for the period of time they've been using it. Untreated substance use disorder, for whatever of those reasons that we just mentioned, is a very big problem in the world, but especially in the United States, where we have a lot more societal problems because of mental health issues and substance use disorder issues than pretty much any other country on the planet. And there's lots of reasons why that exists. Untreated substance use disorder creates increased healthcare costs for everyone. We have lost productivity in employment. People can be hurt in accidents or injury and can die. We have worsened, for the individual and society, worsened mental and physical health. We have increased stressors on our legal, judicial systems, social protective systems, DCS, DHR, everything above. Because of the way that we approach drugs and alcohol in this country. I'm going to have some slides on some commentary on that. I'll try not to editorialize too much. Somebody's talking about barriers in the chat. I appreciate that. Talking about Medicaid. Very few rehabs that take straight Medicaid. I mean, these are all real problems. There are personal barriers to entry, as I'm talking about. So while we talk about these big picture, even the studies that aim to what can we do to reduce these practical barriers? What if transportation was not a problem? What if access to the program that you need when you need it was not a problem? Would you enter treatment? Like, we can make this happen. No cost problems at all. Still, we have a major barrier, and according to this study from SAMHSA, 95% of people with the substance use disorder say, I don't need it. Comes back down to that denial. And a lot of people, especially for alcohol use disorder, they have a desire to not necessarily be abstinent. They're looking for an intervention to help with the immediate crisis, but with an intention to return to moderate drinking, controlled drinking. Okay, I don't want to drink as much as I was before, but I can't imagine life without alcohol, because that is quite a scary prospect in the early stage of recovery. So instead, they would rather have a different approach. I'm gonna drink only on social occasions, and I'll only have a couple of drinks. Seen that one play out many times. A lot of times it does not work. It eventually progresses, and the person is back where they were, or in a worse state than when they originally presented. There is a correlation with the substance use disorder and how long it's been going on, and how severe it is. So the longer things progress, the more compounding negative factors people tend to face. Mental health becomes worsened, medical status becomes worsened. You get emerging health consequences from the use itself. Um, and so speaking about, this desire to control and operate on one's own terms, this is why a lot of treatment, and according to this number, about 30% of substance use disorder treatment episodes are terminated prematurely by the person who enters that treatment. So how someone's talking about how long they have sober. Congratulations to you. Thanks for sharing that in the chat there. So how do we address what is going on? How do we face these challenges, which are very acute to mental health, and especially to this field of treating mental health conditions? Well, frankly, we have to strike when the iron's hot, because the stages of change change all the time. So the stage of change, if you're not familiar, it's a theoretical model. It's been around for a number of years. It categorizes people based on how likely they are to take action. You have different levels of action. You have pre-contemplation. That's where someone is unaware that there is a problem. You have contemplation, where they are starting to think, okay, maybe this is something that I might need to change. Weighing those pros and cons, talking themselves into it, talking themselves out of it the next minute. It's an ongoing process. Excuse me, I'm going to need to stay hydrated. Preparation is, how might I go about making this change and getting some things organized, doing one's research, and kind of looking through that path about what that might look like. You have action, which is someone actually taking steps to change the behavior. And then you have maintenance, which is a sustained remission. One is not listed as relapse. Relapse can certainly happen and take someone back, not necessarily to the very beginning of pre-contemplation, but might take them back to that preparation or contemplative state, depending on the circumstances. Timing is very important. If someone lingers too long in one particular phase, it's very difficult to create action to move them to the next, especially those early phases of change, like pre-contemplation and contemplation. If somebody is contemplating for so long, again, it's that back and forth, talking in, talking out of themselves. While they're feeling bad, it's a lot of, I don't want to do this ever again. I'm gonna figure out what I have to do to not feel this way. But then that gets sidebarred by the new stressors that come their way, the appeal of the use again, because it creates this relief that creates this self-propelling cycle of use. Somebody who gets to the maintenance phase, is important to remember that this is not really a short-term thing. Somebody doesn't get to maintenance in a short amount of time. It does take a lot of sustained work, and that's really what recovery is all about. It's the sustained work every single day, and that is terrifying to some people. And that can be one of the barriers for people staying in a program of recovery or staying in a treatment program. The National Institute of Drug Abuse outlays some principles of effective treatment. I'm definitely not going to read all these to you the way I read the diagnosis, but all of these are important, and they all have implications within the treatment setting. When it talks about behavioral therapies and the effectiveness of those, being responsive to the individual about what their treatment needs are, hopefully all of those are very standard practice. What I highlighted here is talking about enough time. An adequate amount of time is critical. And knowing that just getting someone detoxed, while that is a first stage in the treatment, it in itself is not effective in long-term sustained recovery. And there's figures on that I'm going to show. Treatment does not have to be voluntary to be effective. So we're talking, thinking back to a couple slides ago when people were saying, I don't think I need treatment and all that. There's always a lot, there tends to be many examples of external leverage that works its way on the individual. And some of that is, big picture, like they got a DUI or they got another charge, so they have probation or parole problems. They have DHR or DCS involvement because of child protective services coming in for various reasons. They face consequences on the job, with family, all kinds of different external factors that are influencing someone's desire to be in treatment. And that's okay. Whatever the reason is that got you in the door, as long as you're in the door and in a seat, you're in a good place. Now, working through that and hopefully increasing one's internal motivation should be a goal, but we should not be waiting around for someone to say, okay, I'm ready now. And I think that that's an important thing for families to hear. I think that that's important. Interventionists know this. Anything we can do outside to exert that pressure might propel someone into treatment and into recovery earlier than they would if we just waited around. And frankly, we don't have time to wait around. The way the world is right now, with the way these drugs are, which I'm going to explain more about, we could lose them to death and an overdose long before we ever get that opportunity. So how long are we really talking about? Again, NIDA says, well, there's really no predetermined amount of time, but anything less than about 90 days has limited effectiveness. Now, I know some people read that and they say, oh my gosh, 90 days. I mean, that's a big barrier for a lot of people to go to a continuous 90 days of treatment. Absolutely is. Those programs certainly do exist. Bradford offers programs of that length as well, but it's not where the majority of our patients end up going. These programs can be especially beneficial for specialized tracks, specific interventions related to the needs of this population or the individual. And then, what was I saying? I got distracted. Sorry. So those sort of programs certainly do exist, but here can be the kicker of the whole thing. We can actually take this 90-day model, and you could break it out into different levels of care and still achieve the same principles. So Surgeon General in 2016 outlined some recommendations, generally saying about 3 days to 7 days of medically managed withdrawal program as necessary, about a 28 day to 3 month period of residential rehab, followed by an IOP or possibly a partial hospitalization program. That's going to be multiple days per week for a couple hours, 2-3 hours per day. Doing that for a few months. That's a good foundation there. Followed by traditional outpatient, individual counseling or small groups, usually for shorter amounts of time, less frequency in a week. Might be one time a week, might be one time a month, couple times a month, depends on what the patient needs. This coupled with looking at the environment, somebody in a safe place. So maybe it's sober living that can be an adjunct component to this as well. You can make these services span out well over a year, and then that doesn't even count for aftercare, which is what it typically used to be called, now called more continuing care or continuous care is with some of the verbiages in the literature. That can extend for multiple years even. So someone's asking about treatment does not need to be voluntary to be effective. What I'm saying is somebody doesn't have to be bought in to get into the room, and somebody's giving pretty good examples of what I was talking about there. Somebody might be court ordered. They can still work a very effective program. Lots of people get into recovery because of some other external force and have sustained recovery for many years afterwards. And the stories I hear of those folks, they come back and they say, thank God I got that DUI when I did. That was the moment that changed my life. Thankfully, nothing worse happened than the DUI, and I was an enemy to myself in that moment. And now I am living a sustained life of recovery. So whatever gets you in the room. Okay, I get back on track with this. So we have to have long time. This takes a long time. I'm going to explain more about why we need a long time here in a minute. But instead, the world that we're in adopted a fail first approach. And unfortunately, that's where we're living at. Because the ability to reliably predict who will succeed with more or less treatment is difficult. Read that phrase. I pulled that phrase right from some source that you'll have. Read that is pretty much impossible. I don't know. Nobody can really tell if you're going to be successful in intensive outpatient or outpatient treatment versus detox, residential, and the full continuum of care. But what payers want to do and are doing is they default to the lowest level of care possible based on certain criteria. And sometimes those criteria are internal criteria set by the insurance company themselves. That's fun. What they want to do is put somebody in the lowest level of care until they prove that they cannot be successful, at which point then they will consider allowing this person the authorization to move to a more intensive level of care. Now, I have an ethical obligation to place people in the least restrictive level of care possible. That is very true. But I also have to be realistic about how likely are they going to be successful, knowing what I know from their history, from the assessment that I've done with them, and with my experience. So what this does, while financially prudent for the insurance companies, creates a spiraling system of relapse, because if we are basically the person is being told you don't get access to more treatment unless you fail, to use that word, relapse. Problem is, they might never recover from that. Many times people relapse and then they're gone, and we never hear from them again, and sometimes they die. And that's the world that we're living in. They may never escape this system. It also, just think about the messaging behind that. We know some of you are going to be successful, but for those of you that aren't, then we'll be there for you, but only if you're willing to jump through some hoops. The self-efficacy, the self-talk that has to be associated with this has to be tremendous of, I'm just never going to be successful. And we're losing a lot of people in this system. And this is something that hopefully we as a society can work on, but this is not something that is a state problem. This is not a individual provider problem. This is a nationwide, the way our healthcare system and government functions problem. So vote. All right, soapbox for that one done. Let's talk about why we need so much time. So the spans that I'm talking about here come from a particular author about 20 years ago. You'll have the resources there. It's worth a read. That what they've done is they've talked about kind of 3 stages. So the early stage is usually about the first 6 months, according to what they have written. Very high risk period for relapse. That is absolutely true. Your first 90 days are a very tentative period. That's why it's very important to have lots of insulation with treatment and recovery, just flooding that period of time. Mental clarity and physical health is still impaired, but it's starting to get a little bit better, and people can start feeling better, in many cases soon after they become abstinent. And then what happens is this elusive pink cloud shines over them. If you're not familiar with what the pink cloud is, this is a feeling of excitement and confidence and even euphoria. It's this honeymoon phase of early recovery, and people are feeling really good and they got this. There's lots of for those that are working the program, there's lots of good vibes going along with this. But what I can also see is a false belief about abilities. Their ability to face risky situations, because they're on this pink cloud. They're like, oh, I could be around it and I wouldn't be tempted. I wouldn't have any cravings at all. Okay, that's usually not the reality. In that, hopefully people are learning new ways of handling stressors. We can expect mood swings, and I'll explain more about where those come from in a minute. We have an opportunity here. We got to work on personal relationships, building peer support, building that recovery support group by getting engaged with things like AA, NA, Smart Recovery, Celebrate Recovery, et cetera. I'm going to give you a list of them later and talk about some of the differences. The middle phase of recovery, called the middle stage here, according to this author, second 6 months, so 6 months to a year. This is a period of adjustment, physical, social, psychological adjustments, getting into more routines around working a program of recovery. Some will talk about a grieving process of leaving a previous life and relationship with drugs or alcohol behind. And there's a lot of changes that have to happen. Changes to the support, the people that they're associating with, changes to their routines and what they do on a daily basis. We're reestablishing the ability to feel. A lot of patients, that I've worked with, they have feelings that seem to come back, and they're like, and they're experiencing them, and it's often tearfulness, and sometimes it's odd to them, and they talk about it, and they're like, I haven't felt this in a long time, because they've been numbing out from whatever substance they were doing, and now it all comes rushing back. And that's a scary time too. That's a time where got to insulate people, got to work around them, because that's a time when they freak out and they leave treatment or recovery at that moment because it gets unbearable. We can normalize these experiences. We can surround people with peers in a community-based setting where people are going to be able to say, oh yeah, I know exactly what that was like. I went through that. It's going to get better. And those are all true realities. People need to be hearing these messages consistently to sustain the recovery. And this last stage, according to this one author, is the later stage, 1 year plus. Increasing confidence in the new support system and personal abilities to cope, and having the tools necessary to do so, wherever those come from. Increased stability and comfort in what this new life is and what it means. And advancing through healthy relationship networks and hopefully recovery-focused activities. Why we need so much time comes from a number of places, but one place it comes from is just how the brain works. The brain needs time to heal. Someone's talking about stress management, resilience, affirmation. Absolutely, I agree with you. Stress management is a recovery issue. If we can't deal with stressors, then someone's recovery is on pretty rocky footing. So what we're seeing here, because this is methamphetamine, which is a stimulant, this is likely dopamine activity. And we're going to talk about neurotransmitters a little bit more in a minute. You see the healthy control firing up a lot. Someone who's 1 month removed from using, not firing as solid, but after more than a year, things start to look a little bit more similar to how they did in the abstinent control group. You see that similar here, dopamine on the bottom left, starting to come back for that, in this case, cocaine use after about 4 months in this one diagram. Then on the right side, you see drinking and what they did in that one, and you can read the box, it's about memory. So what I'm guessing those are, that's probably acetylcholine or glutamate activity that is higher. Those are more responsible for focus and learning in our brains. So, and we're going to talk a little bit about young people, but this is a 15-year-old brain. Initiation of alcohol use at any age pediatrically will alter the brain chemistry from there on forward. It just will. And some new research that's just come out that I've been reading in the last, probably 6 months, is talking about how significant that is, and that it may not fully come back to a pre-use state ever. One of the reasons why we need time, and what makes that early period tumultuous for some, can sometimes be attributed to post-acute withdrawal syndrome, also called PAWS. This is something kind of interesting about this field that you may not know about if you don't really work with this population a lot. What we see here could be irritability and hostility, depression, anxiety, mood swings, low energy and fatigue, sleep disruption. It could be insomnia. Usually. Limited ability to focus or think clearly, lack of libido, and just inexplicable pain that comes out of nowhere. This cycles through on a very cyclical basis, and as the cycle continues, tends to diminish in severity, but can last several months, if not longer, depending on how much someone was using, what they were using for, how long they were using it for, and combinations thereof. So I can't tell someone, hey, this is probably how long this is going to last. I can give them some estimates, but it's very individualized, and it's unpleasant and it's scary for that person in early recovery because it feels out of control when they're working really hard right now to try to regain whatever they can to control. So let's talk about what happens during treatment for a minute. Number one, got to break down the denial. That's why it's highlighted. This is really, really important. And if we're doing nothing else, breaking down the denial is key to help someone get into recovery and sustain recovery. I have a whole bunch of other things here. Solid coping strategies. I'm seeing some chats going on about brains but also I'm seeing people kind of sharing some, what do you do in group? What are some things you can facilitate? What are some topics, things like that? Some people are talking, I like this, I'm going to just read what this person says. Family dynamics, boundaries, sober activities, creating new social supports. These are all things that we can do in group and individually with people during treatment to put them on a more productive path. A lot of that is what I'm covering here. We want to work on solid coping strategies and relapse prevention. Stress management is an aspect of that. We're trying to tackle as best we can those underlying issues that are related to the addiction. A lot of times that's trauma. I'm going to talk about trauma in a second. Taking time to heal, to balance. So eating healthy, getting some exercise, all good for the body to heal physically. We want to work on those relationships, family, significant others, whoever this person identifies as family needs to be involved as much as we can. We want to build healthy relationships in recovery if they do not exist. That can be help getting people connected to support groups, sponsors, things like that. Life skills. For some people who enter recovery, we can't take it from a truly rehabilitative state. That kind of has a sounding of we're going to return to a place where they are stable and productive. Some people enter treatment and they never had those skills to begin with. So it's really a matter of habilitation rather than rehabilitation. So whatever those life skills might be, someone might have never had a job. They need help on how do they build a resume? How do they do a job interview? Where do they go to get jobs? What are resources available for them to do that? And this is not just a young person issue. This is not just that college interrupted, emerging adult that, we kind of talk about a lot is they never had a job. They're living on mom's sofa. That age group is expanding and expanding as just time is going on. People's in their 30s, 40s, never have entered the workforce. So if that is part of their overall recovery goals, and being productive and having things to do and being a member of society, I think is important. We need to meet them where they're at. A drug and alcohol free environment, recovery provides that in especially residential settings. That's one of our main focuses is a safe place where people can take that time to not be around their drug of choice, because that is a very difficult exposure early on in treatment. And as people build their foundation in recovery, and the intensity of the care changes and they're working more in an outpatient, there's likelihood that they might be seeing some of those things when they're not in their therapy sessions. So bringing all those pieces together, and as we morph the focus on relapse prevention, the discussion changes from residential to outpatient. The focuses have to change because they're dealing with different stressors every day in those different settings. Coordination of care along this continuum is vital. We have to get people plugged into resources, whether that's immediately as part of the facility and treatment they're getting, or if it's working with outside providers. Following up on medical, mental health, et cetera, needs is very important, and setting them up for success. Treatment has to be more than detox. According to one study, 27% of people who receive detox-only services, not followed by continuing care, were readmitted within 1 year into a public detox settings of services. Relapse is very high risk right after detox. And it's especially dangerous because after a period of abstinence, that tolerance goes down. So what people tend to do is they go right back to using exactly what they were using before in terms of type of substance and quantity. And that can lead to the overdose in itself, that reduced tolerance. According to one study, beginning substance use disorder treatment within 14 days of discharge from a withdrawal management program, like a detox-only provider, perhaps a hospital, showed that we had reduced readmission rates into those settings. Any treatment is better than no treatment. So going back to that person from earlier slides that's putting up the reasons why they don't want to do it. I don't need it. I don't want it for whatever reason, or I'm worried about fill in the blank. Treatment, like a lot of things in life, is additive. A little is better than none in many cases. That goes for everything other than drugs and alcohol. That's the caveat. A little joke there. You know, people have trouble getting into exercise routines because they're like, I don't think I can commit to exercising every day, or I'm not going to be able to exercise long enough. Whatever you can do. If you can go for a walk for 10 minutes after work, that's better than no 10 minutes or 0 minutes of walking. So same goes for treatment in a lot of ways. I'd rather people get exposure to any kind of treatment than no treatment, whether that's a lower level of care that they're able to access, whether that's virtual services because they can't get to an in-person, anything's better than nothing. So one study conducted a 3-year follow-up, and it looked at people who had formal help, formal treatment versus those who didn't. And the differences are there. About 62% remission rate for those who received that formal help compared to about 43 remission rate among those who did not get that formal help. Then when they looked back at these folks and they checked back in about 16 years later, they found that those there were about 60% of those in the group that had not received formal help had relapsed. Compared that to about 43% of that initial group that had that original help had relapsed. So having that treatment helps in the short term and the long term. And this next point here talks about having a primary care visit, like with a PCP. That was associated with remission over time as well. Those with having those routine visits, according to this study, had a 39% higher chance of achieving remission compared to those without such visits. Now, there's a little bit of a logical fallacy built into this if you want to play along. Somebody who's going to their PCP routinely has the means to do that, has the access to do it, and has the wherewithal to be that interested in their overall health. So they're likely going in and talking to their provider, and giving accurate information, and is wanting assistance in treatment and things with all kinds of treatment. So is that person just more likely to be successful with following up on treatment needs and overall health recommendations compared to someone who avoids their PCP like the plague? Lots of good chat going on. I'm trying to read it as much as I can. Some of it's going by fast. Looks like a lot of you are sharing resources with each other, which I love. I appreciate that. I'll try to monitor and answer if anything comes my way particularly. So I want to point out ASAM language. I'm going to tell you more about how ASAM works in a little while. I have a few other things I want to get to first. But ASAM, in a nutshell, it's the American Society of Addiction Medicine, and they create they organize the levels of care, more or less. They look at diagnosis criteria, but it's also where are people likely to be successful based on the acuity of their needs that are organized in certain dimensions, and I'm going to show you those in a minute. Important takeaway is their language changes, and I think this is important to talk about now because even just in the last less than 20 years, look at how ASAM talks about the substance use disorder differently. On the left, we have 2011 language. Talks about a chronic disease. That's true. That's still true. It talks about dysfunction in these circuits of the brain. Dysfunction sounds a little stigmatizing to me. And it talks about pathological pursuing of rewards, that reinforcement that happens. Now, today, since 2019, when they revised it, and through today, this is the language you will find if you look it up on the website or read their book. It talks about a chronic but yet treatable condition that is a medical disease, again, emphasizing that medical model, that talks about how complex the interactions are among the brain circuits, including things like genetics, the environment, and one's life experiences. What's that probably talking about? That's talking about where we live and the trauma that we have faced. People with substance use disorder, behaviors that become compulsive and often continue despite harmful consequences. That aligns it very much with the diagnostic criteria and differentiates a bit more from that pathological pursuing. And then they've added this whole nother sentence: prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. And that's important to remember. And that's why I like this slide. It's actually older, this is from 2020, but I think it's a really good representation. This is a treatable yet chronic condition that needs continuous maintenance in the way that we talk about other medical conditions like diabetes, hypertension, and asthma. And this shows you the relapse rates for those conditions. If somebody's blood sugar gets out of whack, they don't face the judgment of someone that relapses with drugs and alcohol in this world. But it's part of the disease. It's how it works. It doesn't have to go like that. I'm not saying that everybody is destined to relapse. There are plenty of people that that's not the course that they take, but it's not a character defect if that occurs. That is how the brain is functioning. That is how this person is, where they're at in that moment. And they need help. They don't need to be judged and pushed aside in the way that many times society tends to. So we have a lot of opportunity for advocacy. This is your brain on drugs. Just kidding. No, it's really not. But I love the old timey stuff. I'm a victim of DARE. I mean, a participant of DARE. Those were the messages I had about drugs and alcohol. Before that, the Nancy Reagan, just say no. Just say no. How simple. Thank you, Nancy. Wonderful. That's not really how your brain works. This is more how your brain works. A lot more complicated. Here's my caveat as I go into this part. I am not a pharmacist. I'm not a doctor. I am interested in the brain in as much as I had take some courses on it and I seemingly passed them. I do not have an expertise in how brain chemistry works. Some of you on this call probably know a lot more than I do. So I'm going to do just a few slides on brain chemistry and how it relates to drugs and alcohol. So drugs have receptor targets. Certain drugs kind of jive better with certain neurotransmitter receptors. So let me go back. So here's a lot of neurotransmitters. They all do different things. And we have receptors in our brain that are ready for these things. And once the brain binds with these neurotransmitters, it creates a neurochemical reaction, electrical and chemical. So opioids tend to work really well on the endorphins. So what happens is they look like endorphins when it binds to the certain receptors, and a lot of times it might be the mu or kappa receptors. It's going to create what an endorphin would. It's going to feel like euphoria, modulation of appetite, and one's stress is likely to reduce. Cocaine, it binds to what looks like dopamine. So whenever someone uses cocaine, they get a whole lot of dopamine and it feels good, and that's the euphoria. Benzodiazepines work off of the GABA receptors. GABA is the brake pedal for the brain. It slows things down. So that's why if somebody uses benzos, they have a reduction in central nervous system functioning, but also experiences that reduction in anxiety. Alcohol works kind of weird compared to most drugs. So it activates in part GABA, slowing some things down, but it also works on the NMDA. I'm going to spell out what that means in 2 more slides. That receptor, which is really associated with glutamate, and that relates to the intoxicating effects of alcohol. So it's kind of doing a couple things, and that's why there tends to be, in small amounts of alcohol, you get kind of a rush of sort, and then it kind of sways more into the depressant side of things because it's kind of operating on a couple different things. Told you, I am not a chemist. Dopamine, everybody's favorite neurotransmitter. It results in euphoria and a variety of other psychological effects. A lot of these neurotransmitters do a lot of different things. This is mediated by the reward pathway. When we think dopamine, we think reward. The more dopamine you have, the more rewarding the experience is. A burst of that dopamine in this pathway means this is important. I should do this again. We naturally get rewarded with dopamine for a lot of things that just naturally occur in our lives. Food creates a dopamine effect, and our body says, hey, you should probably keep eating that because we want you to stay alive. We get a dopamine rush as well as other neurotransmitters through sexual activity. Why is that? Because our brain is wanting us to procreate and keep the species alive. At the end of the day, we're all just animals. So when we get dopamine, our brain says, this is really important. You probably want to do this again because this works out really, really well for me. Drugs that take this same pathway create this supraphysiological increases. That means over greater amount than the dopamine that naturally occurs. And it exceeds this response to the natural rewards. What that means, if you're familiar with like the studies where like they gave cocaine to rats and they used cocaine and they would not procreate, they would not eat, they would not drink water, they would just continue to use cocaine because it created more dopamine response than just the natural reinforcers that existed in their environment. So we're a lot like animals, and that goes the same way. You are going to have all these slides. Somebody's asking about slides. Glutamate. Glutamate's an excitatory neurotransmitter. It's associated with memory and focus. I've said that already. In general, most drugs modify the release of glutamate in some way. Now, some interact directly with the glutamate, as I mentioned, alcohol. Most interact indirectly, like when cocaine modifies dopamine, which then causes the release of glutamate. So it's there, it's important. Several studies have talked about what happens if we blocked that NMDA receptor, which is one of glutamate's main receptor. And in some of this research, they were saying that the overall self-administration of the drug decreases. So as that reinforcing aspect of the neurotransmitter activity goes away, someone might use less. That's good. So there's lots of opportunity in manipulating these things to assist people to remove the reinforcement of drugs and alcohol. And some of the medication I'm going to talk about today does that to varying degrees. Big points to take away on neurology before I move off of it, because I told you it's my favorite topic. Dopamine leads to subjective feelings of pleasure and reward. Repeated use overrides our impulse inhibition. If we stop, there is likely a bounce back, a return to homeostasis that does occur, and that can create mood dysregulation of the amygdala, executive functioning, create sensations such as anhedonia, just kind of numbed out. This, in combination with environmental aspect cues going on in the environment, creates a motivation system where there's a high priority given on that substance. So can't, in a way, when you look at it like this, it removes a lot of that quote unquote choice. It's if you were in this situation where your brain was firing like this, I can understand that. And it is really, really difficult to argue with one's brain. It's doing a lot of things that evolutionarily have kept you as an individual alive and kept the species going. And our brain can be one of our own worst enemies when it gets hijacked. And that's what's happening here, a hijacking of the brain. And if that hijacking happens early, it's extra significant. They say now the developed brain, they were saying like, okay, mid-20s. Now I'm hearing like mid-30s. I'm just starting to think we never fully have developed brains. That's probably the better way to look at it. Nearly 4 in 5 people in treatment for alcohol use disorder reported that they first began drinking during their adolescent period. Those who started drinking before the age of 14 were more likely to experience alcohol dependence, use disorders, what we call it now, and primarily within that first 10 years of drinking. So that's that early emerging adult period. Somebody starts drinking at 14, they are likely treatment candidate through their mid-20s, if not for longer. They are also likely to experience past year dependence on and multiple dependence episodes by the time they reached adulthood. Those who use addictive substances before the age of 15 were 6.5 times more likely to develop addiction compared to those who delayed their ingestion. So it's why we so much prevention education has to exist for our young people on the dangers. We just as a society don't do very good about painting the real picture about what these dangers are. We tend to use, this is your brain on drugs, just say no. All this stuff that creates a lot of pseudoscience or sometimes just blatant lies around the dangers of substance use. The dangers are there. For the young people, they struggle to play the tape all the way through and see themselves in the future. They think that they're superheroes, that nothing can touch them. They can't picture themselves 5 years from now, 10 years from now, let alone more years from there. And part of that's just where they're developmentally at. So it's a struggle. I'm not saying that there's an easy answer here. There's a reason why it's so hard. Any use of alcohol, nicotine, or other drugs by adolescents is risky, and we have to be very conscientious of that. And as I mentioned, recent research, and this is in my references, they're saying a single dose of ethanol intoxication causes lasting neural changes in the brain, so much that it might never really return to a true baseline before that ingestion and intoxication happens. So there's a lot going on in our brains, and I like to kind of paint it in this tree of addictions, and our brain has a role in this, and the way that we just come out wired, the way that our neurochemistry works from birth is going to have an effect here. There's things that happen along the way that help to create more roots around addictions. And a large part of that is trauma, and then can be an adjunct to that, the shame associated with that, the guilt associated with that, and abuse. So many patients don't always identify that they've experienced trauma. And there's a distinction between capital T versus lower T trauma. Capital T tends to be things that overtly everyone categorizes as traumatic experiences, like a plane crash, like a natural disaster, things of that scope. Lowercase T traumas are the more personalized traumas, the loss of a pet, the loss of a close friend, something like that. That typically that might only impact a small group of people or an individual. Most people have, I'm not going to say most, everybody has experienced a certain degree of trauma. How that was handled in the moment, how one sought support and what that support was, and the severity of that trauma all play a role in how someone moves forward with that. And we have so many people that get stuck in the trauma, and that's why so much work now is on trauma and focusing interventions on um, management of emotional regulation. I'm thinking about like a lot of interventions with DBT or around regulation in that area. We have EMDR and a lot of trauma focused interventions. So we have these roots that are growing and they're all listed there, and it's lots of different things. The branches end up being the behaviors, the things we actually see, and the things we might see might be drug and alcohol use. It could also be, compulsive gambling or compulsive use of the internet or pornography, overeating, shopaholicness, over shopping, codependency, relational problems. So there's lots of ways that the roots of this can spread out and start manifesting itself for the person. If you cut off a branch, it may grow back. And in the meantime, you got lots of other branches to swing off of. And what I'm saying there in kind of a coy way is that's where cross addiction comes in a lot. Somebody starts arresting one of their behaviors. They get drugs and alcohol under control, and then you see them start to become very compulsive in their shopping or their eating, or they take on additional risk-taking behaviors in another way. Sometimes it's sublimated in a way with pro-social behavior. Someone gets really, really into exercising when they get into early recovery, to the point where it becomes problematic. And how would we classify that as problematic? Well, if it starts negatively influencing other aspects of your life. Too much time, too much money, influence on relationships. Spouse doesn't like that you're hitting the gym every single night. Yeah, it's better than you hitting the bar every single night, but she still doesn't see you and she's still mad. So it's complex and it's different for every single person. And it doesn't always take that form, but it certainly can. And that's kind of what I wanted to talk about on that slide and mention, because just because we start getting one area seemingly under control, other areas can pop up pretty easily. Trauma is very important to be looked at as part of our assessment and diagnosis. There is a significant connection between trauma, especially trauma that occurred early in life. We call those ACEs, adverse childhood experiences. And there's a lot of studies about ACEs, and a number of them talk about the correlation with mental health conditions, including drugs and alcohol. Compared to those who do not have any adverse experiences, people who have an ACE score of 4 are twice as likely to be nicotine users, smokers, 12 times more likely to attempt suicide, 7 times more likely to be alcoholic or have an alcohol use disorder, and 10 times more likely to use IV illicit drugs. Each ACE score increases the likelihood of early initiation of illicit drug use 2 to 4 times. If someone has 5 ACEs, that can result in an increased risk of misusing prescription pain medication 3-fold. 80% of patients seeking treatment for opioid use disorder reported at least one ACE. Almost 66% of those reported witnessing violence during childhood. The ACE is very easy to incorporate into your work as an assessment. It is literally 10 questions, and they are very easy to understand. Many patients are even able to answer these questions on their own as a questionnaire, though because it's trauma and we want to make sure we are not re-traumatizing or making these situations worse, might be needed under the guidance of a helper to work through the questions with them. But looking at that is very, very important and certainly correlated with mental health and substance use disorder, if not causal relationship, is what I think we can start deriving from some of the research. No one ever wants to say something is causal, but there's a lot of data that talks about these connections in the same way I just spoke about the pediatric development of substance use disorder. Not necessarily causal, but pretty significant. And through all this, we're asking people to change, and change is difficult, and facing these traumas and the guilt and the shame and the fear is incredibly challenging. Not just because we're talking about physical and mental dependence on a substance, but there's a comfortability that exists for people, who have dealt with these situations for sometimes their entire life. And there's this whole familiar chaos becomes comfortable. The devil you know is better than the devil you don't. I know what the chaos is I'm used to. I don't know what I'm facing if something changes, because it could be worse. And I'd rather just stick with what I know, because at least it's predictable. And I think that through some of that, you actually get people who self-sabotage, even unconsciously, in recovery, to return to a state of known chaos, because it is what they know. Takeaway here, and taking it right out of Big Book, is nothing changes if nothing changes. And I think that that's a very important lesson for people in everything, but especially in recovery. And again, breaking down that denial is vital. And that comes from a place of radical honesty and acceptance of reality, that life on life's terms. And we have to help move people from a place of a solely ego-focused functioning to a broadened insight. Values clarification can be very important, because values often get distorted during active substance use. And then reframing that as people are working to rebuild those relationships and figure out their new foundation and placement in the world of recovery is very, very important. I want to pivot now to something that I think there will be an interest in. I appreciate everybody playing along with the slides. Yes, you're going to get the slides. Lots of people talking about it. Thank you for the feedback. Lots of people talking about ACEs and all of those. People talking about choosing chaos. They're putting a quote in the chat. This is how my whole family is. I've done this since I was 12. Absolutely. A lot of this chaos is transgenerational. It seems to pass on in the norms of this family system many times. And I did a number of years of work specifically with adolescents, and that was always an interesting focus for me, to try to talk with them that there's a world outside of their family system, and that many of the norms that they are having in their family are not necessarily societal norms, and things can be different. So I'm looking at the chat. Sorry, that's why I was trying to pause and take a minute for the chat. I appreciate everybody playing along as you are. For the next section, I want to talk about drugs. While you're here, right? You want to get 3 CUs, you want to talk about drugs. I'm going to try to keep my editorializing to a minimum. There will be a couple moments where I have to share some things. If you have not been keeping up with the news, we are dealing with overdose and death problem, and it's not seemingly getting any better. These figures here show you over the last couple of years. I know some of the data is a little bit older, and the diagram on the right makes it look like, oh, it's kind of teetering down a little bit. Maybe that's positive. The preliminary data I'm hearing for last year is that 107,000 people died of overdoses. That is very preliminary, but that is up. So what has been happening over the last couple of years is the significant increase of synthetic opioid overdoses. What we're talking about there is primarily fentanyl. We're going to talk about what that is in a minute. Cocaine is increasing, as well as other stimulants like methamphetamine and MDMA. Usually those increases are the combination of the fentanyl, the opioid, and this other substance. So we have to kind of take that in stride. I'm going to show you some diagrams about how that works. Prescription pills, coming from the pharmacy, and heroin are stable or decreasing. I mentioned that very, very early on, that it's not as in vogue, in favor as it was. There were periods in our time where, using heroin was chic. They called it heroin chic, and it had a whole lifestyle, counterculture, wardrobe, music scene associated with it, especially it was like late 80s, early 90s. It was like New York and things like that. You don't see that as much right now. You know what I'm hearing a lot in like the music, a lot of talk about stimulants, usually talking about prescription stimulants, prescription amphetamines like Adderall and things like that. That seems to be in vogue more than others. But let's talk specifically about opioids for a minute. The counterfeit pills are abundant. So you've probably seen this in other presentations that either I've done or some other folks have done. Great opioid roundtable week ago, maybe 2 weeks ago. I don't know. I lose track of time. Very recently had a great opioid roundtable with lots of community partners talking about these things. They had a couple slides about this. These are not pills that are coming out of Walgreens, so it's okay. That certainly could happen, but somebody asked me that question on a presentation I did in the last couple months. I'm not seeing any research that is indicating that. These are on the street, and they're being made by the criminal cartels, criminal networks. They're being sold on social media to unsuspecting people at times. This is usually a combination of fentanyl and another substance. Could be methamphetamine, could be something else. You see on the bottom, you see oxycodone, top looking very real because it is, followed by the bottom, which is the counterfeit. Looks pretty much the same to pretty much any eye, unless you happen to be a pharmacist with a great deal of experience knowing the difference between these two things. Same thing in the middle there, that's Adderall, so it's an amphetamine. At the top, it is the legitimate prescription. On the bottom, it is one that is containing methamphetamine. And the Xanax bars on the right-hand side, white, looks real. It is real. Counterfeit one has a little different coloration to it, but that in itself is not the only indication that it is counterfeit. I'm just looking at the chat, making sure I'm not missing anything too significant that I have to talk about. Okay. So this is easily accessible. I saw a lot of things really blew up during COVID. People were stuck at home. People were having stuff shipped to their homes. They were working through social media channels to get things sourced. American Medical Association cited the CDC stating that the jump in overdoses can be attributed to illicit fentanyl, fentanyl analogs, methamphetamine, and cocaine. Yeah, that's what I've said. Rainbow fentanyl, recent thing on the scene. Probably seen some news stories about it. Yes, 40% of counterfeit pills coming into the country have lethal levels of fentanyl. Absolutely. I'm going to show you all about that in just a minute. Very good point. So rainbow fentanyl, scary. Started hearing about it last summer. Now, if you look at like the DEA's website and you listen to these news reports, they're saying, okay, the rainbow, that's to drive addiction amongst kids and young adults. That's really probably not true based on how I understand things to work. Because if you gave one of these fentanyl-laced pills to a kid, they would drop dead in like 30 seconds. The look, the color, the stamping, that's on a street level to differentiate where it's coming from so that people, start looking for, I want to find those red ones. I want to find those, whatever, because, it gives you a certain brand of sorts on the street. So while certainly there is danger of this being introduced to children and all that, and that's dangerous and everything like that, I don't think that that's necessarily the intention of the cartels in the immediate. They want to create customers who stay alive and continue to buy their products. Interesting side note that I found, opioids have a correlation, it seems, with antihistamines. So in looking at opioid overdoses, 18% of the around 92,000 drug overdose cases that occurred in 2019 to 2020, a couple years ago, 18% of those tested positive for antihistamine, most commonly Benadryl. Only 90 deaths total, that's 0.1% of deaths by overdose during that same period only involved antihistamines. So just dying from antihistamines, pretty darn rare, but it's the combination that might have some additive effect. If you have antihistamines and opioids in your system, you have a compounding exacerbation of the respiratory depression. Naloxone, the overdose reversal agent, does nothing against antihistamines. Now, does this mean that people on the street level are also using antihistamines because they have nasal drain? Maybe. More likely, this is somebody that is accidental. There's a certain number that has to exist in there. So people accidentally overdosing who are taking opioids, maybe it's their own prescriptions, but perhaps they're overtaking them, and they happen to be taking antihistamines at the same time, and they just are mixing these two pharmacological agents. This is why it's so important for the public at large, everybody, to, if you're taking medications, you talk to your doctor about any, you tell them everything that you're taking, because there can be counterindications in these medications. Really talk to a pharmacist. They're the ones who really are going to know. They're going to know a lot more than the doctor most of the time. So always talk about, hey, I happen to also take Benadryl every day because of my allergies, which you also may want to look into, because that's actually showing that that's not a great path to take Benadryl every day. That has some brain problems, much as I do, because I don't know how to say brain problems other than brain problems. Anyway, moving on. Xylazine, this is new on the scene. This is interesting. So there are reports, many reports, of heroin or fentanyl being cut with xylazine. Why would someone do that? Well, apparently lengthens the euphoric effects of the other drug, and it is not responsive to naloxone, the overdose reversal agent. This is not a controlled substance. It's used in veterinary medicine. It's been around for a long time, ever since 1962, and they did some human studies and they abandoned them because it was not good for humans because of hypotension and CNS depression. So what they're seeing is intentional use of this and accidental dosing, as in it's getting in the drug and they did not know it was in there and it's causing problems. The graph on the bottom shows the commenting, the attention in Reddit, which what Reddit is, it's an internet community. There's lots of drug stuff on Reddit. There's also a lot of recovery stuff on Reddit. I'm gonna give you some resources later. This was from January of this year. It showed a lot of increase in Reddit community discussion involving this drug in particular. So people are somewhat seeking it out, but also there's just more interest around it. And you tend to go to the internet community chatter to find out what's going on with drugs. I lurk in some of these communities myself just to kind of be aware of what's happening. And I'll give you some more examples of that as we go. Psychostimulants, I'm going to just talk about briefly. Cocaine, amphetamine, methamphetamine. I have for you here the breakdown about how many people are using the substance versus how many people had a use disorder. And I know that can seem kind of weird because you're like, oh, almost 5 million people are using cocaine, but only 1.4 million people had a cocaine use disorder. Like, well, go back to your diagnostic criteria. Maybe that means they did not meet enough of those criteria to be considered a use disorder. Amphetamine, it is very widely used. Just in general, about 1 in 9 people aged 12 to 25 used prescription amphetamines for a non-medical reason or misused them without a prescription. This is the Adderall. This is the study drugs for those college-age students, high school-age students. Oh, someone's asked about methadone and it not touching it, unfortunately. Do I have information on that? I do have a couple slides on methadone coming up. But the way methadone is going to work is it's going to be a full agonist. It's going to activate all of those receptors. I don't know quite how xylazine, if that's what you're asking about, is influencing that. It's probably not, because methadone is very highly regulated. So you're not getting fentanyl. Oh yeah, I'm going to talk about fentanyl. Thank you. They just added that. I'm going to talk about fentanyl and methadone here in a minute. There's actually good news on that front. Methamphetamine, about 2.5 million people using that in 2021, about 1.6 of them meeting criteria for a use disorder, which again, if you look at that, you're like, is methamphetamine use alone probably a pretty red flag that they need, or that they would meet criteria for a substance use disorder? Yeah, I could see that position as well. But you got to go back to the diagnostic criteria that fall into the mild, moderate, or severe. Here's an interesting thing that's going on. In our country, arrests for marijuana are going down. Let's call it in part because of legalization for recreational use, medical use, or decriminalization in states, or more often in community and city levels, while simultaneously methamphetamine arrests are going up. But here's the thing. There are 30 times more marijuana users in a year than methamphetamine users. So how does this really happen? Is it because of increased policing efforts? Is it all of a sudden people who are in possession or using methamphetamines are putting themselves in positions where they are more likely to be encountering police? I don't know, but it's an interesting thing where one who's maybe a little bit cynical could say, well, we just got to meet a certain quota, so we got to backfill with another type of prosecution since we're losing out on the marijuana prosecutions. So I don't know. I'm not cynical though. Benzodiazepines. Before COVID, we were talking about this as more of the hidden epidemic, because it seemingly was starting to spike up. You kind of start seeing those numbers in the 2017 period, where it was just an increase in overdose deaths associated with benzodiazepines, especially in combination with other opioids. Toxicology studies of opioid deaths can find benzos, and they do. And what benzos do in combination with the opioids, it is an additive respiratory depression that might be leading to the overdose or to the death. Some toxicology screens can miss some of the basic benzos. That's clonazepam, Klonopin, and alprazolam, which is Xanax. So we might be missing this in plain sight because we know there's a lot of this out there. About 12.5% of Americans in 2018 used benzodiazepines, often as legitimate prescriptions in their name, because only about 2% misused them. And at that, for that study, what they put up by NIDA, only about 0.2 actually met criteria for a use disorder. So this stuff's out there. And what somebody's talking about, I can't believe doctors are still prescribing benzos like they do, especially because we are seeing a lot of co-prescription of opioids and benzos. And I'm talking about just general population, someone that does not necessarily meet criteria for substance use disorder, someone who has pain and happens to have anxiety, and they go to their PCP and they're telling them all about it, and the PCP writes them a prescription for both. Both of them should be treated with great deal of respect, because a 2016 study found that overdose death rates among patients receiving both types of medications was 10 times higher than those only receiving the opioids. It's the combination that's really scary. I'm seeing a lot of chats, lots of reaction to that. Thank you for that. Definitely when you start thinking about this as aging population, and maybe people who might have dementia, which is what someone in the chat said, they might not be able to understand or take action on some of these risks because of lack of understanding or lack of focus in the moment. So CMS does recommend certain things, and I listed those there, but that's not really the scope of what I want to talk about here. This is an area of concern just as me as a citizen of the world. So you are now more educated on that just as a citizen, and please tell your family. Let's talk about alcohol. Alcohol is an area of problem for the United States and for other parts of the world, but seemingly especially for the United States. And it's only gotten worse through COVID. So the graph here shows the types of alcohol users. As I mentioned earlier, we have about 133 million people who drink alcohol in the past month. 60 million of those would be considered binge alcohol users. That is someone who, for men, have 5 drinks or more, and for women, 4 drinks or more on the same occasion on at least one day in the past 30 days. Heavy alcohol users, which is about 16 million Americans, is binge drinking on the same occasion on 5 or more days in the past 30 days. That's a lot of math. And you're trying to do all those tabulations to yourself. The population of the United States is around 332 million today. And so alcohol is very, very prominent. If we're talking about in the past month, 133 million Americans have drank alcohol, 60 million of those binge drinking, 16 being what we consider heavy alcohol users. I reiterated those points because it's a lot, and it's gotten more significant ever since COVID. And I could go into lots of other slides on COVID particularly. I left some of that out for brevity, but here's some important takeaway. Look at this older data. This is even before COVID, 2015 to 2019. Excessive alcohol consumption accounts for a lot of deaths. About 13% of total deaths for people who are aged 20 to 64. That's a pretty large period of the lifespan. When you shrink that down a little bit and you just look at people who are aged 20 to 49, alcohol is associated with about 20% of those deaths. Now, I'm not saying it's alcohol poisoning equals death, though those are in that data. I'm talking about the medical conditions associated with that alcohol use. We hepatic liver and liver disease, liver cancers. Alcohol affects pretty much every body system. Cancers of the stomach, esophagus, et cetera, et cetera. Pretty much every system the alcohol touches, and that's why it's particularly problematic compared to even other substances of abuse. And then we have the TikTok generation, TikTok, which is everybody's favorite app of disassociation. We have this new trend called the Borg, which I think is very interesting sociological experiment driven allegedly by Gen Zers. The Borg stands for Blackout Rage Gallon. This is a gallon that somebody takes, a gallon, you fill it up with water, drink of some kind, non-alcoholic drink. They say you can put up to 750 milliliters of a spirit in it. That's a whole fifth of liquor. Haven't done the math to make sure that actually works. And then they put in caffeinated like flavor booster powders. They usually have electrolytes, and the stuff that's like the post-workout or pre-workout gym stuff that you mix in with your water, and it's supposed to give you all the healing stuff that Gatorade was marketed to do for so long. This really started coming out early this year, and you see a lot of young people doing it. Some have even said this might be a, quote, harm reduction approach. And here's what they're thinking with that. If, let's say you don't put a full fifth of vodka in your Borg, but instead you measure out, I'm going to put in 4 shots of vodka, and I'm going to mix it with a whole bunch of water, and I'm having electrolytes and all that stuff. That is me controlling my drinking. And if this is all I drink at the party all night, that's pretty good. It might even be an improvement for that individual. And what I gain by having it in my own gallon that I carry around and I have a top on, my chances of somebody dosing with, date rape drug, MDMA or something like that. Rohypnol is the date rape drug, by the way. If I cap it, I'm reducing my risk that happens, and I'm keeping myself out of danger. Some people are kind of talking about it like that, and I could kind of see that. So I don't want to like blow that whole thing up. But it's not a harm reduction model if you put a fifth of vodka in it for your afternoon activities at the tailgate. Okay, so this is kitschy, this is something, but it is an area of interest. And if you work with young people, adolescents, college age, knowing the vernacular, I think is pretty important to know. And this is one of those things. Somebody's talking about they see where people might use this as a mean to look like they might be drinking without pressure to use. So maybe they don't even have alcohol in it. Nobody has to know. I like that. That's harm reduction right there. Nobody needs to know that I just have water, food, electrolytes, food coloring, or I just put Gatorade in it. I like that. I hadn't thought about that. Thanks for the chat. Marijuana. Everybody loves to talk about marijuana. Marijuana is increasingly complicated. Here, I'm going to show you a few reasons why. Marijuana is the most commonly used federally illegal drug in the United States, federally illegal being the key term there. A lot of Americans ingested marijuana in this data 2019. Approximately 3 out of 10 people who use marijuana have a marijuana use disorder. Sometimes you see different numbers on that. Like if you just Googled that, like that'll pop up. Some put it as less, closer to 10%. Consult your DSM for more data. Though keep in mind your DSM is pretty old data. Marijuana affects the brain, you did not know, by impacting memory, learning, attention, decision-making, coordination, emotional regulation, and our reaction time. This is especially dangerous for those with underdeveloped brains, those people who typically we talked about 25 or less. Now I'm talking about 30, 35 and less, and probably anybody else. Sustained chronic use of marijuana is going to affect all of these systems. What some of the highest stakes risks, I want to say, are with those with pre-existing mental health conditions, and maybe even conditions they're not even aware about yet. And it can propel psychosis, symptoms of schizophrenia, and things that look a lot like that. And some of that we can attribute to the very, very high potency THC that is out on the streets today. It is not your grandfather's marijuana. It is high potency, 20, 30, 40% potency compared to who? So there's this new thing, a brand new condition since about 2004. Cannabinoid hyperemesis syndrome. I always mess up on that one. This is cyclical vomiting caused by a continuous ingestion of high potency THC. And what goes on for these people is they have this urge, like this innate urge to like, I gotta get in a hot shower or a hot bath. And that actually does alleviate the symptoms temporarily. So it's just really weird though, that like they have this compulsion to do that. And there's been an 8% yearly increase in hospital discharges for persistent vomiting after cannabis legalization compared to pre-legalization era. So this is being propelled by increased access to marijuana, increased access to high potency marijuana, and seemingly an increase in people regularly using marijuana. When we talk about marijuana, we kind of have to talk about CBD because it's on the hearts and minds of so many, including maybe some of you, and certainly plenty of patients and people that we interact with. So cannabis has a lot of compounds in it, cannabinoids, 100 plus, some say more. THC is that mind-altering substance, and there's different types of THC, which I will elaborate on in a moment. CBD, cannabidiol, but now usually just called CBD, is one of the cannabinoids. Now, it is not mind-altering. It does not get you high the way THC does. Problem is, it has to be really pure CBD to not have that effect. Most of the time, people are buying CBD and it's hardly CBD. It's not really having the benefits that they think it's going to have. And it can even be adulterated with THC. So there is a chance if somebody's taking what they think is just true CBD, they could test positive on a drug screen for THC. Now, marijuana is consumed in a lot of different ways. You smoke it in joints, bongs, pipes. It can be vaporized. You can have transdermal patches and gels and balms, and people can eat it through edibles and drinks and pills like capsules and tinctures and all kinds of things. It's quite the booming market. Now, I do want to differentiate right quick. I'm not talking, when I speak about marijuana, I'm not talking about K2 and spice and all that stuff. That is just truly synthetic, not real marijuana. This is some kind of material that's been sprayed with some kind of psychoactive chemical. It looks a lot like potpourri. Often found on the internet, sometimes in head shops, depending on local jurisdiction. You never know what you're getting. Buyer beware on anything, but especially this stuff. People smoke it, brew it in a tea. This is the stuff where, you know, the people have the jitteriness, increased heart rate, blood pressure spikes. That's where they really start having the negative trip from these substances, and these are the folks who often end up in the ER and they took something and they're not really quite sure exactly what they took, because who knows what's in this stuff, and it's dangerous, and it can cause health consequences, and it could cause death as a combination of these factors. Now, to pivot a little bit, because we still got talking about marijuana, we got this kind of new interesting space, and this is the area that I think this stuff's interesting. So I'm not as big into the brain stuff, but I think this is interesting. So historically, federal law did not differentiate between the hemp plant and the cannabis plant. Both were made illegal in 1937 by the marijuana, you have to say it like that because it has an H in it, not a J, Marijuana Tax Act, later solidified by the Controlled Substances Act of 1970. The Controlled Substances Act is brought to you by people who think that cocaine is less dangerous than marijuana, because cocaine is a Schedule II drug to this day, and marijuana is a Schedule I, meaning it is no accepted medical use and has a greater likelihood of dependency if abused compared to cocaine. These are these people. Told you I wasn't going to try to editorialize, but that's a weird thing. Anyway, fast forward a little bit, 2018, we have the passage of the Farm Bill, Agricultural Improvement Act. What this allowed was a broader hemp cultivation and the transfer of hemp products across state lines. Hemp is an agricultural product that has a lot of uses. The goal here, let's increase research with hemp utilization in the critical agricultural material. Please do, somebody said do I choose, okay. Critical Agricultural Materials Act. Hemp by definition cannot contain more than 0.3% THC. Otherwise, it's marijuana. So what the definition in this bill does is it silos THC. It says it's basically specifically Delta 9. That's what, if you're smoking marijuana, it's probably Delta 9. But what that does is it leaves an open interpretation space for all these other cannabinoid compounds, all these other THCs that exist that are not Delta 9. So boom, here comes Delta 8 on the scene. Man, COVID really, and I tell you, it's COVID. People stuck at home, 2020, 2021. People are Google searching, how am I going to get high? Delta 8 increases 850% in Google searches. Sometimes this is referred to as THC light because it apparently has a slightly weaker attachment to the CB1 receptor. That's what produces the euphoria, the high. Delta 8 is only detectable in trace amounts in plants, but if you extract it from the CBD, if you extract the CBD from the hemp, because remember, the Farm Bill now allows us to do that, and you apply some chemistry, well, then you get all these new compounds. Now, there's legislation, some that has even popped up in Alabama to try to limit this on a state level. May 2022, this was one that got a lot of publicity. They upheld in the Ninth U.S. Circuit Court of Appeals that Delta 8 was legal under the Farm Bill. I read an article that popped up on my news feed because I get all kinds of weird news because of what I tend to search for various presentations. I got a pop up on my news feed last night that some area in Georgia is fighting this battle as well. And there may be some additional limitations on access to this substance in Georgia. But what's happened is we've had this explosion of products, Delta 8, Delta 10, THCO. And that's what they're saying to that is that is 3 times more potent than these other products. Now, recently, just in last month, about a month ago, the DEA has recommended that this be classified as a Schedule I substance because of the nature of how it is produced, which is more synthetic than the other means. They say that it should not be classified in the same way. HHC is also sold on shelves right next to this stuff. It's been around for a while, usually in smaller quantities. It is not technically THC. It seems to metabolize different. Again, I'm not a pharmacist, I'm not a chemist. So all this stuff is out there and it's in stores. I'm not telling you to go seek it out. That's the opposite of what I'm trying to do. I'm just saying if you can get access to it easily, so can people who need help with their substance use disorder. Someone's asking, is this why we hear more about Delta 8 more in Tennessee and Alabama? I think it depends on where you go. I hear about it a fair amount here. I'm in Alabama, but I also have a lot of family and connections in Tennessee. I'm in Tennessee a lot. I'll tell you, walking down the streets in Nashville, sometimes I see people put out like a little table they're sitting at, and they have signs that say Delta stuff. But you know what the signs say in Nashville? They don't say Delta 8. They say Delta 9. And you look at that and you're like, wait a minute, I thought, when did marijuana become legal in Tennessee? Well, it ain't. But here's what they're doing. And this adds to all the confusion. They are synthesizing Delta 9 through this hemp process. And it's on the shelves right next to the Delta 8. You can buy Delta 9 as long as it has less than 0.3% THC. It is a hemp product and can be sold under the Farm Bill. Now, in states where there is legal marijuana, legal Delta 9 marijuana, there's lots of states now, seemingly, but those are the states that push back the most. So looking at this graph here, this is where is hemp-derived Delta 9 legal. In many states in blue, it's legal under the Farm Bill. The states that push back the most, Idaho, where it is completely prohibited, North Dakota, Colorado, California, and Washington. Majority of those states have legal Delta 9. So here's my editorialization. They're pushing back on this product because they are then losing the revenue, because you can often buy these products for less and at places that are not as regulated as the dispensaries, which carry a heavy tax burden for the people running that business as well as for those who are purchasing from that business. So go figure who's against it, those who have financial means to lose. What are some problems with this stuff? Here's some problems with all this XYZ 1, 2, 3 deltas. This is not FDA approved. You got to be buyer beware. There are dangers in this. There are stories about people getting access to these Delta products, and it has something different in it, and it causes negative effects. I know of one case of a young child whose death has been attributed, and I think it was in South Carolina, to consumption of Delta 8. Now, how did that really work in practice? I did not read, the report from the not mortuary. Man, I made it 2 hours without struggling over a word. I'm doing pretty good. I didn't read the death certificate report. I only read what was in the news. So a lot of times what happens with marijuana deaths in general and the pediatric exposure is it's deaths through another means, but coroner, thank you. It's deaths through another means, but it's because they were under the influence that, you tie them closely together. So these products can contain dangerous chemicals, heavy metals, all kinds of things that are not good for health overall, short-term or long-term. The synthesizing process can create that and be dangerous. Now, in practicality, it's likely not any more dangerous than smoking or ingesting Delta 9, as in true marijuana for most users. Because especially in legal states where people have access to marijuana that is regulated, that's relatively safe in terms of you're not going to get heavy metals and you're going to know what you're getting. It's not going to have fentanyl mixed in. It's coming from a dispensary. They have too many controls for that. You can have adverse events related, and those are increasing, as I mentioned. For most users, they're going to have hallucinations, unpleasantly. They're not going after those. Vomiting, tremors, anxiety, dizziness, confusion, and potentially loss of consciousness per the FDA. Pediatric exposure rates are going up. That's just likely to happen as more of this stuff is out in households, and it's the age-old problem with some of the marijuana products is they're marketed to kind of look fun like other candies. You get stuff that it's an edible and it looks like a Reese's cup, and a kid sees it and they're like, hey, Reese's cup, I love Reese's cup. They're going to eat it. They don't know what they're eating because they didn't read it or they don't understand it, and there we are. Luckily, in a lot of cases, those can be managed through medical care, consultation with poison control, etc. There's no way to differentiate Delta 8 versus Delta 9 on your standard urine drug screen. So if somebody's going out in a legal state and purchasing Delta 8 and they're using it and something happens, work calls them in for a random drug screen, they get into an accident and it's called for, who knows, all kinds of different scenarios. Nobody's going to be able to know whether it is you were using the illegal Delta 9 or the Delta 8. And that's pretty scary. So think twice on whether you choose to pursue these things that, while technically legal, have a lot of interesting implications nowadays. So I like talking about that. I think it's interesting the crossroads we are at with drugs and public policy. I find that interesting. But that's not the only reason we're here. Let's turn back to treatment. Let's get back into this track, right? What does treatment look like? It's got to be individualized, got to be different, not necessarily different. Every person is different. So treatment has to be individualized. We have to evaluate individuals and help them to define and work through their own needs and their goals. We have to have an integrated approach that works between different professions: medical, nursing, clinical. We have to use evidence-based standards of care. We have to match the setting and intensity with what their needs are, and that changes over time. That might be somebody starting at residential and receiving detox and then stepping down to a less intensive level of care as they progress. It might be starting them out where we think that they can be successful and where they would like to start, which may be an outpatient setting, and seeing how they do. I know that can seem contradictory to what I was saying about the insurance model, but as long as we are using our expertise and following the desires of the patient, then we are usually on the right path. I mentioned ASAM, but I was going to tell you more about it. ASAM, Addiction Society, American Society of Addiction Medicine, developed in the 1980s a set of criteria for providing outcome-oriented and results-based care in the treatment of addiction. Treatment of addiction, compared to other areas of mental health and especially medical focus, tends to be more of the Wild West, with less regulation and less focuses on outcomes. That is changing as time is going on. I, for one, personally participate in outcome-based monitoring of effectiveness of care that is either being driven by payers or organizations like the Joint Commission, which I'll be speaking about in a moment. So we're slowly getting there, but we're definitely not at the same level as other medical services. So what ASAM does is provides a nomenclature for describing that continuum of care, the continuum of the addiction services. And there's a link to it in there that you can find out. Here's how it works. Levels of care are on the top of your screen, and the dimensions that are associated with each ASAM is on the left-hand side. And you look at what's going on with the patient, and let's go down the list a little bit. You look at acute intoxication and withdrawal potential. Are they actively intoxicated right now? Are they going through withdrawals, or is it likely they're going to go through withdrawals very soon? If that is all true, then you need to be looking at, okay, they're probably going to need at least a level 3, maybe a level 4 type facility. That's the first place you start, because medically it's the most acute. And if those exist, that might trump everything else. And okay, this person's going to be sick, and they are sick. We need to be treating them in the right setting. Biomedical conditions, complications. So do they have other medical things going on or likely to go on that we need to address in a setting? If they don't have any of those, maybe they do okay with the lower level of care. If they do have those that are concurrently needing attention, higher level of care. Emotional behavioral conditions, that's concurrent mental health stability. So, are they stable with, maybe they're already diagnosed with depression, anxiety, PTSD, fill in every mental health condition under the sun. Or they're not diagnosed with it, but they're exhibiting the symptoms. And so we need to work on identifying that and appropriately and managing it as we can. Somebody's working on a paper using the ASAM model. That's very fun. Good luck to you. Treatment acceptance resistance, how bought in, this is a stage of change. Resistance to working a program. Somebody who has a lot of self-motivation and likely in the contemplative or action stage of change maybe does not need the intensive setting that someone who is in deep denial that does not see their use as a problem. We're probably going to need some more intensive interventions for them, and on. Relapse potential, what's based on their history, based on their current circumstances, what do we assess their risk level is? And similarly with recovery environment, based on where they're living, is it a safe, sober place, or do they need a structured setting where they can start their journey of recovery? So all that to be said, it gets organized like this, a true continuum. Someone who is very, very stable and maybe meets only mild diagnostic criteria and is not at any medical or mental health risk, they might need outpatient or even early intervention services on the left side of your screen. As you move further to the right, the intensity of the level of care increases. You see 2.1, intensive outpatient. That might meet 3 or 4 days a week for 2 to 3 hours a day. Ramping it up for partial hospitalization, a 5-day-a-week program. A half-day partial would usually be about 3 to 4 hours a day, full-day partial at least 6. Into the more residential areas, those 3s, and there's minor nomenclature differences between them. As you move further to the right, they become more medically driven. So at one point, more clinically managed in an intensity level, but then 3.7 in particular is medically monitored intensive residential inpatient services. That's largely where Bradford operates in 3.7 and 3.7 detox facilities. So that is driven by regular involvement of medical and nursing care because many folks are getting withdrawal management services in conjunction with their therapy. And what are we doing during all this treatment? Well, to reiterate some of the things I've talked about, we're reinforcing structure and support to begin early recovery and work on a relapse prevention plan. We are creating a system of accountability and monitoring. We are connecting them with sober peers, not only within a treatment community, but outside by using things like 12 AA, NA, and etc. Monitoring to track process and modifying that treatment as necessary based on progress and patient desires. We are addressing medical, social, and psychiatric needs as necessary for the person, because we have to address the whole person, the co-occurring nature of these disorders. We're helping to work on self-confidence, building resiliency, those life skills I've already mentioned. Intensive interventions and treatment modalities to address that dual diagnosis, the medical conditions and criminal justice involvement as necessary, as based on the presentation of the patient. Opportunities within this to create specialized focus if we have a population that has chronic pain or grief or trauma or something like that, where we can use the community to address these issues in a group setting or individually. And again, assist connecting with continuing care and community self-help and long-term needs along the continuum of care, because this will change in intensity as people are doing better and are more stable. They will need less intensive services. There has to be something to catch them downstream to continue to reinforce these things. As I mentioned earlier, going through with detox services where someone gets you medically stable and then nothing after, very, very, very unlikely that person is going to be successful. Let's talk about the characteristics of my opinion, quality service provider. I'm going to talk about each one of these in brief as we go. Accreditation. Accreditation can be a very important thing for an organization to seek out. There is always within our states licensure and certification, and those are very important and important operationally. Accreditation brings in another set of eyes and usually more rigorous standards in certain areas, especially related to coordination of care, patient safety, and other indicators that demonstrate that a provider is providing the utmost quality of care based on worldwide observational standards. The Joint Commission is a worldwide organization. CARF is more nationally, I believe, if I'm correct in remembering that. Joint Commission is the Joint Commission on Accreditation of Healthcare Organizations, and CARF is the Commission on Accreditation of Rehabilitation Services, focuses a lot more on drug and alcohol treatment. Bradford, we have sites that have either CARF or Joint Commission. No rhyme or reason for one or the other, just they have it. It means that a standard of care is set by this organization, and you are routinely reviewed based on those standards. Now, I know a lot of things can be said about Joint Commission and flaws that they've sometimes been given in the past. If you've listened to my talk about Joint Commission being an initiator of the fifth vital sign being pain in the 2000s, which in some ways propelled some of our opioid prescribing practices. I do believe that in spirit, the Joint Commission is focused on quality outcomes, patient safety. There have been, of course, unforeseen consequences from that. So I just want to make sure I'm kind of showing both sides of the coin here. Evidence-based treatment. We should all be using evidence-based treatment. That includes medication management, therapies such as CBT, not CBD, don't be confused by that, CBT, DBT, CPT, EMDR, and MI. That's cognitive behavioral therapy, dialectical behavioral therapy, cognitive processing therapy, eye movement desensitization and reprocessing, and motivational interviewing. We need to be incorporating psychoeducation, didactic materials so that we are educating our patients. Again, we cannot take for granted that it's truly a rehabilitative focus. Habilitative is name of the game, and we are exposing people to information that maybe they did not have. And by educating people and they are gaining insight, we might be helping to reduce some of their denial. We need to be incorporating 12-step facilitation or a support group connection of some kind. That can be varying based on the treatment program. Contingency management helps to reinforce within a community. It's very important. It's very helpful within community settings, but it can also be used individually to reinforce the positive behaviors, such as negative drug screens over time, and incorporating peer support. Someone's asked about clinical hypnotherapy. That is an intervention. Don't use that as a primary method of intervention in a lot of the work that we do, but I definitely see its part. There's going to be a couple things I'm going to mention that are a little bit more akin to that towards the end, some newer areas of focus. So thanks for playing. Programs that use cognitive behavioral therapy, contingency management, MI, and medications generally have more effectiveness than programs that do not use these interventions. And it's very important we use that interdisciplinary team, as I mentioned. Medication is very important, and medications that exist specifically for the treatment of substance use disorders should be incorporated into our treatment modalities. There are currently no FDA-approved medications to help prevent relapse from substances other than alcohol or opioids. Though I will have a couple things on that in a minute. You got to stay around to the end. Examples of medications I'm talking about. I'm talking about methadone, talking about buprenorphine, talking about naltrexone, acamprosate, Campril, and disulfiram antabuse. I'm going to really hone in on the methadone, buprenorphine, naltrexone for just a minute. The graph on the picture on the right shows kind of how these interact with our neurotransmitters. Methadone is a full agonist, so it binds that neurotransmitter. It creates the same effect as the opioids, and that has benefits, and I'm going to explain those benefits in a minute. Buprenorphine is a partial agonist. It works with those neurotransmitters. It creates a partial reaction. That's what helps address the cravings and the withdrawals. But it also does not create the same degree of euphoric effects as other opioids. And then naltrexone, it is the blocker, the antagonist. It sits on that neurotransmitter so that if other opioids are in someone's synapse, it will not react on that neurotransmitter because it cannot get access to it. We have lots of goals when incorporating MAT, MOUD. I've talked about those terms a little bit. This is a moral imperative that we are incorporating medication and that patients have an option for these medications. The goal is to restore stable physiology, reduce the risks of someone overdosing, i.e. dying. This will promote psychological rehabilitation and a non-drug using lifestyle, because taking a medication is not the same thing as going out and buying illicit drugs on the street that you don't know what they are. These are medications. We are reducing the symptoms and signs of withdrawals. We are eliminating or reducing cravings, and we are blocking the effects of alcohol and opioids. I'm going to talk about each one for just a second. Buprenorphine reduces opioid cravings and withdrawals, has pretty limited side effects and counterindications compared to most medications. This has less abuse potential than methadone, and it's less likely to result in medically significant harm if misused because it has the ceiling effect built in. Methadone doesn't have that ceiling effect. If you keep taking methadone, you're likely to overdose because you have too much dose. Buprenorphine doesn't exactly work like that. It has a certain built-in ceiling effect. It's harder to divert it, or misuse it, I should say, because buprenorphine in combination with naloxone, Suboxone, if you try to manipulate that, the naloxone becomes activated and will block the effects, actually send somebody into precipitated withdrawals if they try to do it. They will not get that euphoria. This does have to come from licensed, trained, with a caveat, physicians and some clinics. It's often more available to get this in places where methadone is harder to get. Now, buprenorphine and fentanyl, someone was asking about fentanyl earlier. This is really like where the rubber meets the road. First bullet point, or the first point, sounds a little bit too much language. Here's what the takeaway is. Buprenorphine reduces the harmful effects if someone ingests fentanyl because it creates less disruption for the breathing, and it protects against fentanyl-induced respiratory depression. So having buprenorphine in someone's system and then they ingest fentanyl, they are to a greater degree protected. Thing with fentanyl is it lingers on those receptors longer than other opioids. So there sometimes has to be a longer period of time before induction onto the buprenorphine, or else the patient will be sent into precipitated withdrawals. It works that way for every substance, but fentanyl hangs around differently. People talk about, well, what about buprenorphine being misused? It largely isn't, based on the data that I'm providing to you here. 2019, nearly 3/4 of US adults reporting past year buprenorphine use did not misuse their prescribed buprenorphine. And most who did misuse it reported using prescription opioids without having their own prescription. So again, they weren't taking it to get high a lot of the time. They were taking it to not go into withdrawals. They were self-medicating to address the problem because maybe they didn't have access to buprenorphine on their own. A 2023 study indicates that increased buprenorphine access during COVID-19 was not associated with increased proportion of overdose deaths involving buprenorphine. And then the graphs show you the levels of misuse. Here are a couple quick issues with it. Demand often outweighs the supply. I'm going to talk about supply in a second. Red tape. Some of that has been reduced. So it used to be that there were prescribing limits and you had to get this X waiver on your DEA license for a prescriber to be able to administer it. Just in January, they removed those requirements. So that's kind of a new thing. More to come about that. I'm going to talk more about that in just a second. This cannot be, it's not always available in every area. It is more expensive, often even compared to methadone. There is a risk of misuse, diversion, and noncompliance that exists with any medication. And there is a community perspective of those in recovery that this person is not in recovery. They are, quote, not clean because they are using MOUD. So are we on, or do we have progress being made? As I said, in January, SAMHSA and the DEA issued guidance on the removal of the X waiver. So now prescribers do not have to have it. This has potentially loosened some of that red tape that's been a problem for a long time. And we've been talking about it for a long time. And it really got momentum during COVID when there were a lot of waivers put out there around MAT operations. But a lot of this really stems from the Mainstream Addiction Treatment Act of 2021, passed in February 2021. Previous requirements were you had to go through a training and you were limited to how many patients you could have on the medication that you'd be writing for. Now, we are expecting additional guidance to come out. They said it's going to come out in June 2023. What that'll likely be is another type of training that people have to do in general for their DEA license, but it's not going to necessarily be tied to a waiver, that X waiver that we've known for so long. There are supply issues with buprenorphine. A study found that only about 20% of pharmacies actually provide buprenorphine. A lot of times this is self-imposed quotas, usually by the big players in the space. For whatever reason. And there's little to no wiggle room on growing that. Some pharmacists, and what I'm quoting here, and you can look up the resource I had on the article, it was more focused on some of these smaller mom and pop type pharmacists. And they have a fear about dispensing this product because of the stigma around it and the fear that the DEA is going to pop in there and go and ransack them, because it's happened. They see a whole lot of buprenorphine being sent out of a particular pharmacy. They say, oh, that's a doctor shopping operation if we've ever seen one. We got to go after them. And it's not always. Sometimes it's the community, that's where they're at, and they need access to the product. Red flags that seem to bring up the attention of the DEA more is if there's more Subutex versus Suboxone. Suboxone has that naloxone component. Subutex is straight buprenorphine. It's easier to divert and misuse. It just is. And then filling prescriptions for those who are traveling from out of state. There's crackdowns and criteria that do exist around these things now. But you got to think about this in practicality. Like I'm thinking about Alabama. We have a lot of people that live in the North Alabama area where the closest pharmacy to be for them might be in Tennessee. And they might not be able to get their medications because of the red tape that is presented through this out of state prescribing that looks suspicious to some. So sometimes we try to help and sometimes we end up hurting. There's a relatively new product that can answer some of our diversion concerns, and that's a depot shot called Sublocade. It's buprenorphine that is given in an injection once every 28 days. The injection is in your abdomen, so it's a little off-putting for some, but once every 28 days, and it's there, and you don't have to take any medication every day. Pretty good deal. A 6-month review of global treatment satisfaction done from October 19 to May 20th, published in Journal of Addiction Medicine, found that there was an improved treatment satisfaction compared to people taking these sublingual films of buprenorphine, probably for the reason I just said. It's a once every 28 days, set it and forget it kind of a medication, and it slowly releases the medication that the person needs. Pretty cool. Methadone. Methadone has been around for a very long time. It is kind of the granddaddy of MAT. Methadone increases the amount of time that people stay in treatment. There's lots of studies that say that. It prevents relapses on illicit opioids, and it decreases crime rates associated with illicit opiate use. There's lots of kind of data that correlates criminal activity with MAT initiation. Evidence demonstrates that methadone, MAT, is more effective than just short taper somebody with, detox them off and get them into nothing. You got to have somewhere for people to land. Detoxing followed by zero medications is a dangerous position to be in. Some disadvantages with methadone. It can produce dependence and tolerance because the way it works, as I said, is a full agonist. It fully activates those receptors like any other opioid. The longer you take it, the less that use is going to have an effect, and you have to end up taking more of the same substance to get the same desired effect. So to get the same effectiveness, I'm not talking about getting high, excuse me. I'm talking about effectiveness with curbing their withdrawals. So that is a inherent problem with this medication, and that's where one of the things that happens is somebody who's been on long-term methadone, they often are on a very high dose that they've had to increase over time, and ratcheting that back is not easy or fun. It is time, labor intensive, and not pleasant for that person who's needing to reduce that medication. Excuse me. Coming off of methadone down the line is said to be quite difficult, maybe as difficult or worse than other opioids, because of the way that it works on those receptors. It is dispensed in specialized clinics. This is not something you go to a doctor and they write you a prescription that you fill at the local pharmacy. This has to come out of what are called OTPs, opioid treatment providers, and they have a lot of regulations on them. Now, some of those regulations, were lessened a bit because due to COVID. They had increased take-home flexibilities for 1 year that started around November 2021. It was a continuation of what had already started in 2020. What this allowed the OTPs to do was dispense 28-day take-home doses to those patients that they deemed stable, 14-day doses for those who were deemed to be less stable. Now, there is consideration that some of these mechanisms could become permanent, though I'm pretty suspect on that, based on what we see about some other things that are getting tighter and tighter since COVID, like tele and all those things. So these changes have received widespread support from HHS. Preliminary studies are showing that increased engagement in treatment, improved patient satisfaction, and there are fewer incidents of misuse and diversion than I think some might suspect. And they said, despite a near doubling of take-home methadone doses during COVID-19 the increase in take-home doses was not associated with negative treatment outcomes in methadone adherent patients. So it's working. But why would there be any resistance to how that could continue to work? That's what they do in other countries. Canada uses a much looser model and has pretty good results. A survey of 170 methadone clinics conducted by the Oregon Health and Science University found that despite loosened guidelines, fewer than half of patients were actually even permitted to have a take-home 14-day supply. Why could that be, we wonder? Well, OTPs are generally reimbursed on a fee-for-service basis. So the more services you have, the more reimbursement you have. So if you get them coming every day, that's more points of service than once every 7 days, even more than once every 14, and certainly less than once every 28 days. And most methadone clinics operated in the United States are run by private for-profit companies, 41%, in fact, which is actually increasing from about 13 years ago. Now, this is all according to the Pew Charitable Trust Foundation, and they reported that many states, fewer than half of the OTPs are taking Medicaid, so they're taking dollars. They want contacts. Wonder if there could be something to that. Role of telehealth. As we all probably have experienced, and the fact that I'm talking to you on Zoom today, we have some incorporation of telehealth in our world. And if you're like me, it kind of propelled itself when COVID hit. That first week was kind of fun, wasn't it? And for many of us, we've incorporated this into our continued practice. And there's probably good reason for that. We're getting to access patients that live in rural areas that have those transportation barriers that I talked about earlier, and the schedule and the work conflicts and all the things that got a little easier with tele. And there's some research that it's also helping with overdoses. So they say here that receipt of OUD related telehealth services during the pandemic was associated with increased odds of the MOUD retention and lower odds of medically treated overdoses for these people. Emergency expansion of telehealth during COVID gave us a lot of flexibilities. What I am seeing is some indications that some of these waivers are ending or are about to end. And the future landscape about what this means from a number of perspectives, whether that's standards of care or payer reimbursement, those are very tentative right now. And as the public health emergency will be coming to an end in the next couple of months, formally, the Biden administration has already expressed their support for ending the public health emergency. It'll be anybody's guess as to how exactly all of this lands. So buckle up and wait around, I guess. Let's talk about Vivitrol. Vivitrol's fun. Naltrexone is the actual name of the drug. Naltrexone can be taken orally, but Vivitrol specifically is the intramuscular injection. Again, like Sublocade, works every 28 days. Unlike getting shot in the abdomen, though, it is in your upper hip buttocks area. Here's the benefits of this. Because it is an antagonist medication, it sits on those receptors, it blocks the euphoric effects if you take an opioid. Originally, the research really focused on alcohol, and there is efficacy that it works there too, but it stuff really works well with opioids because it has such a high affinity for these neurotransmitters. It's very strong bonds this medication has. When someone is on this medication and things are reaching that state of homeostasis in a lot of other ways, they're starting to be able to focus on their other biopsychosocial needs, we get more time in treatment to work on helping them get the skills to live a sober life. Now, patients have report that they feel good because they feel like they can't use on Vivitrol because it's not going to do anything. they won't feel those euphoric effects. Now, it's not uncommon for patients to test that, to go ahead and take an opiate, see what happens. And a lot of times they come back and they say, hey, you were right, nothing happened. And I'm like, yeah, I know I was right. I told you, I'm not lying to you. Now, issues, it can be expensive. Now, there are coupons and things that the pharma company will do to help with that. Sometimes just the route of having it be an injection is off-putting for people. Same thing works with Sublocade. You do see a degree of non-compliance. People who might get a shot or two and then they drop off and you don't hear from them again. Don't know if they've chosen not to pursue their medication anymore, or possibly they've had a relapse. Demand for the prescribers does outweigh the supply, but sadly, still a lot of prescribers seem to not always know about this, even today. There are side effects, there are risks. This does have a black box warning because of liver impact. Very small chances, but it is important for the prescriber to monitor liver functioning. Probably a good idea anyway for most people with a substance use disorder. So that can kind of just get taken care of itself through the course of quality treatment. Somebody's asked about what are the dangers about needing pain relief in the ER if the ER is not aware you're on Vivitrol. I love that question, Gail. That's a great question. Here's how we get around that. Somebody's on Vivitrol. When they are given naltrexone, they are given bracelets and necklaces that show that they are on Vivitrol. A lot like how other medications can interact in a hospital setting. So it shows the ER staff that this person is on naltrexone. Then they can use a different type of medication, one that is not an opioid, that'll work on different receptors to provide those same, whether it's pain relieving or analgesic effects. Now, I know not 100% of patients wear them. That is the problem, but it's where education is so very important. Now, in reality, if somebody walked into the ER and nobody knew they were on Vivitrol, they might try with an opioid and they might find it's not working. They would hopefully be quick enough to say, let's try a different medication. So then they're going to maybe use a non-opioid to see if it works to get that efficacy. So it's a really good question, really good discussion. It comes up all the time. Thanks. Going back to quality, I'm a little off my medication talk now. Off my medication. That sounded funny when I heard that back. I'm done talking about medications. I want to talk about other qualities of quality service provider. Family involvement has to be incorporated into quality treatment. The role of a family or even a singular concerned person, because really family is however the person defines it. Just getting someone else involved in the treatment of the substance use disorder is really important and can make all the difference. Families play a key role in that early intervention, getting people into treatment and sustaining their motivation to stay in treatment. Somebody gets a little bit of sober time under their feet and they're starting to feel pretty solid in their foundation and they're saying, hey, I think I can handle it. I think I'm ready to go. Using that leverage of family saying, we really need you to stay there longer can make all the difference. Again, not everybody has to be willing, you have to be willing to follow through, but the leverage can come externally. There's lots of resources available for families. Al-Anon, Nar-Anon, and others. There's lots of resources even within here, our state of Alabama. I know not all of you are in Alabama, but there's lots of resources for families. Studies do show that engagement with family has positive impacts on initial engagement, retention, and completion of treatment. And truly, we're talking about a systems perspective. No one person lives outside of a system. Family system, relationship, work, everything's systems. You can't do relational work without working on the relationships. And these relationships often will reinforce themselves. So let me give you a couple bullet points on kind of what starts happening. Patients, the client is starting to have some increased openness, honesty about what they're going through. They're learning how to share about when they are having cravings or urges or using thoughts or using dreams. And they're being told, a program of honesty and openness is we need to be able to share those things and talk through them and all that. Well, if the family isn't also incorporated in that, that's very scary for the family member to hear, because all they are hearing is this person is right where they were before. And they don't know any different. We have to coach them and educate them on how to get this information, what this information really means, and how they can support their loved one, but also how they can support themselves. The patient and the family need education on managing expectations and how to address speed bumps as they come up, because they will come up. So some activities that can be done, people writing their story of their use, their kind of history, and being open about past behaviors, and that is a revealing period for family who often don't know everything, because it in many ways is a disease of secrecy. And then family writing things like impact letters that are shared directly with their loved one, that provide that healing for them, so that they're feeling heard about how they've been impacted, and what their expectations are for moving forward. This family system, this support, has experienced a trauma going through discovery, with whatever discovery means. On occasion that can be, we really had no idea you were using drugs and alcohol, and this is a brand new revelation, excuse me. But oftentimes it's more, I didn't know the full extent of it. I saw that you were using again. I saw that you'd been drinking more than you used to, but I didn't know the full extent. And maybe I didn't see that because I was in my own denial, because I was in a process of enabling, and my own codependency I could not break out of, being able to talk through that with you. Now that family continues to operate on those exact same principles through, re-experiencing that trauma, recreating that trauma until the using behavior stops. But the thing is, just because somebody stops using doesn't make all of the other stuff go away or immediately repair itself. And that is often off-putting for patients. Patients, confront their family and they say, I'm doing what I'm supposed to be doing. I haven't used in X amount of time. You should trust me now. Okay, they should trust you now after 2 weeks, and it's been a 5-year journey of the pain. Okay, we need to recalibrate our expectations, in a nice way, I'd say this, and help that person who's in early recovery to understand, and help that family to know that, okay, things are getting better, and we understand you still have residence with this. You're still, everything is still very, very tentative, and I totally understand that. But let's give some credit where credit's due, and helping through navigating that. That's where the family work really is, and that's a lot of fun work. That's very important work, and it's hard work for the facilitator, the patient, and the family members, but it is so very important. And as mentioned before, continuing care has to exist. And this, many times, we talk about continuing care kind of in the world, and that can be follow-up therapies and things like that, but this can also live kind of outside of that, in support groups for those who are leaving treatment. Bradford, as an example, offers continuing care for those patients that have gone through treatment. It is a support system available to them for years after they have completed their primary episode of care. So they can continue to come back. They don't have to come back every week. They could do check-ins once a month. It's really up to them, but it's a support group there that exists in addition to the publicly available support groups of things like 12-step meetings, Smart Recovery, Celebrate Recovery, things like that. For many, there's a need for ongoing medication and support after their primary treatment. There has to be a long-term plan here. Because remember, those stages of change are not static. They will not stay in maintenance phase forever. They can backslide. That's where people start thinking like, maybe I could have one more drink. Maybe I could use one more time. It's a special occasion. And going through that dilemma in their head. Somebody's reference to the tip 39, I think that's the family one. Thank you for that. Lots of tip out there, so you can look up those resources, often easily downloadable in PDF form. We might need to be helping people with sober housing, employment, as I've mentioned before, and continued need for family involvement. 12 steps are an important aspect of treatment in terms of initiating people. Sounds weird, but really introducing people to the 12 steps and getting them comfortable with what that means as a support group, but also working the steps. I'm a major proponent of things like AA and NA because it is associated with greater likelihood of abstinence. And here's what the data says: consistent, early, and frequent involvement with these, probably about 3 or more meetings a week, is associated with better substance use disorder treatment outcomes. If we begin the 12-step participation while they are in treatment, especially as part of their group meetings held in the treatment community or by bringing in things like bridge groups, and then reinforcing 12-step attendance at the same time, that is going to have better outcomes. Involvement appears to lead to a decrease in subsequent alcohol and drug use, and it leads us to the conclusion that evidence supports the causal pathway between 12-step attendance and abstinence. It works if you work it, people. That's the takeaway for that slide. Some people are kind of down on 12 steps. There are alternatives, especially, as somebody's kind of said, there's the issue of religiosity that bothers some people. Guys, in my experience, 12 steps is not a religious program. It is certainly spiritual in based, as someone has said. It is spiritual, not religious, but seeing in the literature, seeing on the walls with the steps, the word God, that can be off-putting for some. I get it. Again, education, coaching, this is what I would tell all the patients when I was trying to introduce them to 12 steps. Don't let that be the thing that keeps you out of the rooms. Plenty of people who are agnostic or atheists who are in AA, and it works for them. It works if you work it. Take what you need, leave the rest is another one of those goals. But if it is just so off-putting, there are other alternatives. Smart recovery, and there's others here, but smart recovery, this is self-management and recovery training. It's a secular approach. It uses a lot of cognitive behavioral principles and motivational incentives. Started in the early 90s. There's good outcome data here that it has similar successes to AA. Depends on how you define goals too, because some of this also incorporates some controlled drinking, if that's the goal of the person. Other things, celebrate recovery, I've mentioned a couple times. Refuge recovery, which I'm learning more about, has kind of a Buddhist slant to it. So pretty neat, especially if you're inclined for that in your spiritual journey. Women for Sobriety, SOS, which is Secular Organizations for Sobriety, and Life Ring, Secular Recovery, which I looked into a little bit. It seems to have some kind of like goals built into it, like some achievements. So maybe it gives people a little bit of target motivations to watch, like kind of watching an exercise program kind of a thing. I don't know. But support groups landscape changed, and COVID blew the whole thing up. And people had to go do the Zoom things, and we're getting back more and more in person, and a lot of it's resumed kind of as normal. But some communities lost support groups that have just never come back online. Some people are moving more towards online options. So I'm going to mention a couple of things, and I bring Reddit up again. I think Reddit's interesting. I learn a lot of things on Reddit, but they have recovery-focused subreddits. So these are subgroups that you can join. Someone did a research looking at the subreddit called Opiates Recovery. And they looked at 31,000 people, and they looked at their engagement. And the engagement was measured by like how often they were commenting in the threads. It's like a chat in a way, a forum, if kind of old school internet. It's like a forum. So they looked at 31,000 people. Here's a few takeaways. The greater the number of online non-drug related groups an individual recovering from opiate use disorder became part of, the lower risk of their of use of episodes over time, relapse, by a small percent, but still there. There was a benefit to engaging in forums devoted to recovery, But there's also a risk of if people were too narrowly focused on those recovery focused forums, that they might relapse. So message for that one is there's a good balance. Somebody who's just super singularly tunnel vision focused on just the recovery community, might not be getting enough other data, not other things to fill their head and spirit and all those things. So good to just get lots of exposure to different things. The third point, participation in the forum focused on substance use was not associated with a risk of opioid use episodes, indicating that the interaction with people who are discussing substance use may not necessarily be harmful for those in remission. Now, anybody who's maybe been a personal participant or understand how AA works can definitely understand that last point. Hearing the story of the person's struggles in a room does not mean that that person is at the person hearing that is at greater risk of going out there and drinking. In fact, sometimes the opposite works. It's like, oh, don't want to be like that guy, or this only reinforces my commitment to my recovery because ... So kind of an interesting, thoughts takeaway from that. Here are others though, because I know that Reddit's not for everybody. A few of these are Reddit. Tempest exists. I do not get any money from them. I've never used them. I don't know anything about them. I'm just doing the research for you, so you don't have to. Plans start at $15 a week. Allegedly, you get calls and live events and community events as part of this recovery community. They are touting reductions in cravings and using days in the months that they're looking at the data. Try it. I don't know. It might be good. Other Reddit things. Redditors in recovery is all Reddit is free. Stop drinking. Stop drinking is an interesting one. In the Rooms exists and has existed for a number of years. They do online 12-step meetings and can feel live and interactive. And LGBT Teetotaler started in 2016. So for those who are maybe looking for LGBTQ plus focused recovery and community, there are options out there for you and your clients. Here is one of my, I'm nearing the end, I'm watching my time. People do recover. A lot of times people want data on like, hey, how many times does it actually take to go through treatment before someone's successful? It depends. The average number of treatment attempts before success, whatever that is, can be success can be defined in a lot of different ways, depending on the study and research you are reading, is usually is 5. 5 is the average, but the median is 2. So there's a lot of outliers for people who go through a lot of treatment. And I've worked with many of these individuals at different points in my career. But the thing is, some people might be 2, might be less, might be 1 time. There is hope in however someone is approaching recovery, whether it's the first time or 5th time or whatever time. People take diverse pathways. Getting assistance formally through treatment, going to 12-step groups, going to outpatient counseling with folks like y'all. Sometimes people do it with and without medication, though I will stake my position that when it comes to opioids, medication is the standard of care. And some people are externally leveraged. They have something that pushes them into treatment, and some people just decide they're sick and tired of being sick and tired, and that's all it took, and they get in there and they work a program. Now, I want to turn the last couple minutes while I have you to some interesting developments, some things we may want to look at for the future. And this is certainly not an exhaustive list. There are devices that exist. I know of 2 manufacturers right now that are doing devices like this. These are external electrical stimulation devices. What they do is they fit behind your ear, and there's little tiny needles that go in. They provide mild electrical pulses in the surface area where there's nerves and cranial nerves, and they stimulate the production of those endorphins, the feel-good neurotransmitters. What that does is it can fill opioid receptors because it looks like an opioid, and it eases the withdrawals. So the graph they show there shows reductions in the withdrawal symptoms for somebody who's been using the device. Is this device covered by insurance? Good question. Probably not. Some of them are FDA approved, but not a lot of the times it's not its own procedural code. Monitoring cortisol levels. So what is cortisol? Cortisol is a stress hormone. It increases glucose in our body, sugar. When we get a dump of sugar in the bloodstream, that's what triggers fight or flight. I got to get out of here or I got to fight. People who stayed in treatment, and this was in this study, abstinence-based residential treatment, less than 90 days had a higher initial cortisol level than those who stayed longer. So their fight or flight is firing. They're scared out of their mind. They don't even know they're scared. Their brains tell them they're scared. So elevated cortisol that they measured with salivary samples, plus what was the status of their relationship, usually if they're in a more stable, committed relationship, the better, and how high was their ACE score, or in this case, if they had a higher ACE score, they discontinued treatment earlier. Now, there's a potential here. What could we possibly do with this information? Well, we could start maybe monitoring cortisol levels somehow. That might help guide some decision making about this, intensity of care and the longevity of care. I've mentioned about a little bit naltrexone, which is the naloxone, which is the opioid overdose reversal agent. And I saw a few of you mention that you carry naloxone with you. I do as well. I have it in my backpack. I have it with me everywhere. Here's the inherent problem with naloxone. Someone who's overdosing, not really going to be successful in giving it to themselves. They're usually incoherent, passed out. And it's usually the bystanders that have the greatest effect of administering the naloxone. Well, what if there was a device that someone could be wearing? Someone who is using opioids, and this would sense any changes in breathing and movement and all of that, and then it would administer the naloxone to them. Now, not FDA approved, done some pilot studies that exist in the world. I think that's a really cool area, and it really does fix an inherent problem around naloxone reversal overdoses. Maybe someday we're going to have a medication for stimulant disorder. I've been hearing about this since I've ever learned about Vivitrol, because they were talking like, oh, we have some studies that indicate this might be effective. Well, a couple years ago in the New England Journal of Medicine, they talked about some study about combining the injectable naltrexone, Vivitrol, and bupropion, which you may know better as well, Butrin. And what they said is that when they combined these two for folks with moderate to severe methamphetamine use disorder, it resulted in those in that group compared to the complete placebo group having less positive results for methamphetamine at their follow-up appointments. Something to that. And that's something I think within our grasp today. Now, there's lots of talk about, well, I want to say novel approaches, but they're not novel. And what I'm talking about now is hallucinogenic assisted therapies. So, and there's been a lot of talk for different treatments. Ketamine gets a lot of discussion when it comes to the treatment of depression that is resistant to our typical arsenal of antidepressant medications. This is not necessarily that new. This has been around for a while, and there's even stuff going back 50 years about incorporating hallucinogens in conjunction with therapies that yield better results than therapy alone. And this is the next wave coming. And I kind of couple it here in my last closing minutes to say it needs future focus. I'm personally interested and excited about what this could mean. But it's an interesting irony we find ourselves in, talking about drugs and problems associated with drugs, and then the drugs might also create opportunities for healing too. And so ketamine is one of those. Ketamine has been around and people do abuse ketamine. I'm not going to say that they don't. It's a very small number of people. According to the research I saw, less than 1% in the United States. This drug was granted FDA approval for the treatment of depression back in 2019. And it's even indicated that it improves abstinence rates for alcohol and opioid use between treatments. Similarly with psilocybin, which is starting to get legalized traction. And I show you that graph there of, this is the most recent data as of November 2022. I don't think it's changed since then. In some areas of our country, psilocybin, magic mushrooms, are legal. Most of the country, for all of the country, it remains federally illegal, much like how we handle marijuana today. But there's a lot of efforts around legalization and states regulating centers for personal and home cultivation and use. It's estimated that almost 10% of individuals in the United States have used psilocybin one time in their lifetime. I thought that was an interesting number. But my point is, I think that this is going to have a role in treatment down the line. I think in 10 years, 20 years, I think that it's going to be a very different scene. Similarly with MDMA, though I'm personally less excited about it for various reasons. What can you do today, though? Go get some Narcan if you don't have it, naloxone. Keep it at your agency, keep it on you, keep it in your practice. Use screeners on people that you are working with, even if they're not presenting with drugs and alcohol problems. Inquire about that in your assessments. Get competency in this area. And if you don't know, you know a specialist. Let's call Bradford and get a consultation and talk to us about how we can help. Here are a couple homework things for you. You may find a benefit for you personally or for your patients. I'm not an expert on everything on every single aspect of what I'm about to show you. So if there's something objectionable you find in the content, once you dig into them, I didn't read every single page. But there's good apps out there. Some of these are good for patients, like sober trackers. They can track their sober days and various other things. I'm a big podcast person. There are sober related podcasts, and here's a couple of them. I found that the Sober Cast, I've listened to a number of those. I liked those a lot. Those were AA speakers. I like bibliotherapy. I think there's a lot of good stuff out there that can help to decrease some stigmatization, show some what's really going on in this world. Sober curiousness is a kind of emerging thing, and especially with COVID, with the increase in alcohol use, there's a lot more people who are like thinking, I think I might want to just drink less. Here's a couple good books, The Alcohol Experiment and The Naked Mind. Those are good reads. I like Recovery Mind Training. It talks about a lot of the things that I have talked about today, except the book is that thick. It's written by a really, really smart guy, and he can tie together a lot of the history of treatment as well as where we're going now. I like some of these shows like Dope Sook and 4 Good Days. 4 Good Days is a really good demonstration of Vivitrol that I've never seen on camera before, and I'm happy that Vivitrol is in a Hollywood movie. That was pretty fun to see. Lots of different references out there. You're going to get all these slides. These are just resources for you. Here's an important resource I want you to make sure you have. Contact Bradford if you or your loved one is struggling. You have a patient that you need to turn over to the experts. They're going to need some treatment. You can contact us at that phone number there. We got a good website, lots of good resources on the website, as well as information about future and upcoming trainings. We're going to do ethics in June. Check it out. We get 3 more CEs for you in June if you are so inclined. Follow us on social media. I got the time. It's 12 o'clock. That means I got to stop talking. I could keep going. I love talking to everybody. I appreciate your engagement in chat. I'm going to bring Kendra back on. She's gonna close us through what we got to do. I do give opportunity if you want to linger around and ask some questions in chat. I'm going to do my best to answer them after Kendra does what she needs to do. Thank you.
All right, and thank you again for a great presentation and discussion, and to our attendees for your engagement. This concludes today's sessions. We have now posted the evaluation link in the chat box. Remember to be on the lookout for the post-session email with materials from today's presentation and survey link to complete the evaluation for your CE certificate. The survey will need to be completed within 30 days in order to receive your CE credit and receive your certificate. We hope you can join us for future topics scheduled later this year. I hope you all have a great remainder of your day.